Good morning, good afternoon, good evening to all our esteemed faculty, speakers, and participants who come from all corners of the world, right from United States all the way to Japan. So I'd like to kickstart the first international masterclass in gastric cancer with peritoneal metastasis. We are looking at East meets West. We have eminent speakers from Japan, from India, and from Tubingen, Germany, to tell us about the best practice guidelines for intraperitoneal therapy for gastric cancer and systemic therapies, including Hipec, PIPAC, Laparoscopic, Hipec, NIPS, bidirectional chemotherapy, and systemic options. So this meeting is conducted by the Apollo Cancer Centers and Apollo Proton Cancer Centers, and we greet you warmly from wherever you come. So we know that gastric cancer is the 5th most common cancer in the world, and the survival is dismal. Just 1 in 4 patients survive to beyond 5 years. The standard of care for many, many decades has been surgery and intravenous chemotherapy. But despite marked improvements in the quality of surgery and in intravenous therapy, a high recurrence rate persists. The 5-year overall survival is only about 25% in Europe, and it increases quite a lot in Asia and Far East, especially in Korea and Japan, to about 40 to 60%. And we'll hear more about this from Dr. Yonemura about what they do, which can bring about such impressive results. But what is important is among patients receiving R0 resection, about 80% of patients will still recover within 2 years, and the median time to death from time of recurrence is 6 months. So it's a very aggressive and dismal cancer to treat as of now. So it's important to know that many patients with gastric cancer will present with peritoneal metastasis at first diagnosis, as high as 20% even for apparently early gastric cancer, and up to 40% at first diagnosis synchronous for more advanced primaries. So in essence, I would say that about 1 in 2 gastric cancer patients or even higher will present with peritoneal metastasis either at presentation or during the course of the disease. And often this is the event which predates death. So if you look at this, essentially a lot of patients come with combined recurrence, peritoneal, locoregional, distant, and peritoneal. So isolated peritoneal recurrence, the group of patients we are looking at may be about half the patients who present with gastric cancer with recurrent disease. And the survival is dismal to say the least, usually measured in months. Even patients who have the cytology positive peritoneal disease do very poorly. And the role of IP therapies is how to identify and prolong survival in this group of patients who often have only peritoneal disease for prolonged periods of time. So we know that recurrence can occur by spontaneous spreading from the primary tumor and also surgical trauma, where we know that after surgery, we transect lymphatic channels, we may have closed margins of resection, and even with curative resections, we have tumor-contained blood spillage, which can then implant and grow back. And this is what this flowchart shows, that how cancer implants occur due to a combination of serosal invasion with surgical trauma, lymphatic transection, and bleeding, which forms fibrin clots, and the nidus for disease. So a lot of data has come from the National Cancer Registry of Japan. So basically, it shows that more than 50% of death in patients with gastric cancer is due to peritoneal carcinomatosis, and it's the most common cause of death in patients who have undergone radical surgery with curative intent. So peritoneal carcinomatosis, all of us have seen patients right from medical training decades back. They are miserable at the end with bowel obstructions, bowel perforation, bowel fistulae, malignant ascites, which becomes a problem with repeat visits to the ER, and nutritional deprivation and inanition. So recognizing that it is locoregional disease rather than systemic disease means that we have the option of using intraperitoneal chemotherapy very effectively in combination with cytoreductive surgery. So we have essentially then 3 strategies: either systemic chemotherapy followed by surgery, which is the American strategy, and which we follow commonly here. Second is what Dr. Yonemura will talk about neoadjuvant intraperitoneal chemotherapy, repeated till cytology is negative, and then surgery with curative intent Hipec. Third is, of course, upfront surgery with Hipec, which has been shown some promise in the study by Yang in Beijing from China, which increases median survival from 6.5 to 11 months, but it's not standard of care. So this is the flowchart we would use essentially, and these are the things we would be discussing during this meeting. So systemic chemotherapy, unfortunately, though it works well for patients with solid organ metastasis, has not really done its job in patients with peritoneal mets. So of course, we await Dr. Raja's expertise to take us through this field and show what can be done in the current era. Surgery alone, even though we like to think as surgeons that we can conquer mountains, can never be therapeutic. So we are left with IP chemotherapy, which is an exciting regional treatment modality where we can achieve high intraperitoneal concentration exposure. The drug penetration still, unfortunately, it is not as deep as we would like. It's only about 3 to 5 millimeter, even with Hipec. So the role of PIPAC, and Dr. Reymond will take us through this journey of inventing and discovering PIPAC. Should be a fascinating study and talk about what can be done with PIPAC for gastric cancer. So bidirectional chemotherapy, of course, is the other cornerstone pillar of treatment. And so combination of complete cytoreduction, NIPS plus peritonectomy and NACT, all of it is required. So this is true multidisciplinary, multimodality therapy coming to the best outcome for the patient. Sugarbaker summarized the data, especially work done by Shimada, which shows that for peritoneal cytology positive patients also do extremely poor with hardly any 5-year survival. But what is impressive is a simple technique like intraperitoneal lavage, large volume lavage with 10 liters of more normal saline in sequence can achieve impressive outcomes. So combination of IP chemotherapy plus peritoneal lavage will produce a survival as high as 35 months in this group of patients versus 16 and 15 in patients with just chemotherapy and surgery alone. So important thing is that ascites by itself, removal of ascites by itself is a valid treatment endpoint because ascites by itself, apart from the blood supply of the peritoneum, can nourish peritoneal metastasis. So the lower the ascitic burden, the less the chance the peritoneal metastasis can grow. This requires both intravenous and intraperitoneal therapy. So just palliating malignant ascites itself may allow patients to have better quality of life and live longer. So this is what I think Dr. Yonemura will talk about, the SOGI 1998 algorithm, how we will treat patients diagnosed with peritoneal carcinoma at diagnostic laparoscopy in gastric cancer. And these are all the different therapies which are in vogue and which will be fleshed out in the course of the next 90 minutes or so. So one important thing is, can Hipec be used as preventive? We know it is used as therapeutic. Preventive Hipec, unfortunately, is not proven to be of benefit in studies for colon cancer, for example, such as the Profile Chip study. But the Gastric trial is out of Berlin, the Charité Hospital in Berlin, which is looking at curative intent cytoreduction with Hipec versus cytoreduction alone after systemic therapy for locally advanced gastric cancer with peritoneal metastasis, will be, I think, ready by September 2021, and this analysis is eagerly awaited, whether prophylactic Hipec will help. And sorry, not prophylactic, therapeutic Hipec. And Gastric, of course, is looking at prophylactic Hipec. I think Dr. Glehen's group looking at prophylactic in patients with high risk for gastric cancer recurrence, T3, T4 cancers, lymphovascular invasion, bulky nodal disease. But this is also something we are eagerly awaiting. So I think we are at the state where, we have to take Schopenhauer's words to heart. So we know things are ridiculed. Nobody would think that gastric cancer peritoneal metastasis could be something thought of as a curative option or where it could effectively palliate for several years. Hope that after this meeting, we will take back important notes and it may be accepted as being self-evident. So I think we have already crossed the barrier of what is humanly possible with such meetings. So only those who will risk going too far can possibly find out how far one can go. I think that's an apt setting to start the meeting as quoted by T.S. Eliot. Thank you. And I'll now call upon Dr. Ajit Venue, who is a senior medical oncologist from the Royal Hospital, Oman, to introduce our speaker, Dr. T. Raja, who is the Director of Medical Oncology at Apollo Cancer Centers. Ajit, if you can please take over and introduce eminent speaker, Dr. T. Raja, will talk about systemic therapies for gastric cancer. Thank you. You're muted. Ajit, you're muted. Ajit, you're muted. One second. I think he's muted.
We are unmuting you, Dr. Ajit.
Yeah, thank you. Yeah, thank you, Dr. Ajit, for this kind invitation, and gives me great pleasure to introduce Dr. T. Raja. Actually, Dr. T. Raja needs no introduction in India. He is one of the best-known medical oncologists heading a very large, very busy clinical oncology department in Apollo hospitals of India. He's also academically very, very brilliant. He heads the DNB program, author of many investigations, many trials, and also as a clinical oncology, he's got multiple awards, including the Times Healthcare Award, the Best Doctor Award, and also he's a gold medalist, which I didn't know, I just knew about it now. So that's fantastic. And he's really, I mean, you will see it for yourself. He's one of the most sought after speakers in the meetings because of the logical way he presents the data. And I'm really looking forward to this, Dr. Raja. Please go ahead.
Dr. Ajit Venur, thank you for your very generous and kind introduction. And Dr. Ajit Pai, thank you for putting us all together for this, very exciting meeting. It's a very, I would say, it's a less spoken topic, and so therefore, thank you so much for putting up this particular topic on the podium, so that it gives us. We may be doing several things, but it gives us a reason, and some important things could be collected together, and we start a new perspective on this. Thank you for that. So my brief is to talk about gastric cancer with peritoneal metastasis systemic therapy, and I would review what is available and what can be done. And Ajit Pai did talk about the cancer burden, particularly in India. This is the Globocon 2020, and it puts that the stomach cancer, gastric cancer is the third most in men and the sixth common in women. In men alone, the annual incidence is 40,000 plus cancers of the stomach in India, and 20 to 25,000 in women. So put together, we have about 60,000 plus new cases every year. That's a large number. And Dr. Gulia Montari reviewed the treatment that is available for peritoneal carcinomatosis, and kind of looked at what is peritoneal metastasis. And he would note that at the intraoperative abdominal examination, peritoneal seeding is seen in 10 to 20% of the patients who are scheduled for potentially curative resection, and 40% of those at stage 2 and 3. And up to 20 to 50% of the patients treated with radical surgery will develop post-op peritoneal recurrence. And this is seen in 54% of the patients who died of recurrence after surgery for gastric cancer. Dr. Roman Yarema, in a recent publication, again kind of summarized the introduction to this topic and said that the peritoneal mets is the most frequent site where the metastasis occur, and is also the first site where the recurrence occurs, and it is seen in 60% of all recurrences. The median overall survival is poor whenever you have the peritoneal metastasis at 3 to 4 months. Even with the best possible palliative systemic chemotherapy approach, you can only produce an overall survival of about 8 months. How is peritoneal burden assessed? This is very commonly done by the surgical colleagues, but just for the sake of the topic, there are multiple ways to assess the peritoneal burden. One of the commonly used staging system is Gilly staging, or the Leon score, which is staged as stage 1, 2, 3, and 4, wherein the tumor nodules are defined as 5 millimeter or less, or 2 centimeter or less, and the location is at one part of the abdomen or diffuse whole of the abdomen. Then they are staged as stage 1 to 4. Another way of calculating the peritoneal disease burden is the peritoneal cancer index, wherein the abdominal cavity is divided into 13 pelvic abdominal sections, and in each section we evaluate the degree of carcinomatosis by points, 1 to 3 points, and the total maximum value of PCI could be 39. These are the sections just for the audience. And another very commonly used staging system is the Japanese Gastric Cancer Association staging system for the peritoneal burden. Peritoneal carcinomatosis is staged as P0, P1, 2, and 3. P0 is malignant cells in the washings of the peritoneum, and P1 is the single met in the upper floor of the abdomen above the colon, and P2 is single mets in all departments of the abdominal cavity, and P3 is the diffuse carcinomatosis. And this Japanese gastric cancer staging system has got a bearing on the overall survival, and you would see that the overall survival depends on the staging system. And in P1, the 1-year overall survival is 47.2%, and in P2, the 1-year overall survival is 22.2%. And in a review of the gastric cancer and peritoneal metastasis burden, Roman Yarema would summarize the following on the status of the peritoneal metastasis disease and also the efficiency of the current treatment methods. And that was a 200 patient retrospective analysis in which he looked at palliative chemotherapy, palliative gastrectomy, and supportive care, and the efficiency of such approaches in the peritoneal metastatic disease. And in summary, what Roman would say is that the median overall survival for patients with P1, P2, or P3, according to the Japanese staging system, would be only 9.8 months or 6 months or 4 months respectively. And palliative gastrectomy can add to the can improve the median overall survival in P1, but in P3 it doesn't do well, and palliative chemotherapy is probably better and can add to overall survival in the P3. P2 is an area where I think everyone has to work together. And the median overall survival as per the peritoneal cancer index PCI of 1 to 6, 7 to 12, or 13 plus different subgroups will be again 8 months, 4 months, and 4 months respectively. And in patients who have a P3, according to the Japanese staging system, and the PCI of more than 13, palliative gastrectomy did not do well and palliative chemo fared better. And the median overall survival is better only in patients with a lower peritoneal burden, which can be defined as either P1 or PCI 1 to 6. That's the status of this disease. And this is the review of the Japanese German database by Dr. Rao. The German database is another large database for peritoneal diseases, and a total of 235 patients were included in this review. Dr. Rao's review would again classify the patients as from either a low volume center or a high volume center. Low volume center were defined as dealing with less than 20 cases per year, and a high volume center more than 20 cases per year. And you would note that in the German database, pre-operative chemotherapy was given for as high as 78 to 82%. So let's see what happened in their database. The overall survival and the disease-free survival for patients with peritoneal metastasis of gastric cancer is still very poor. As per the German database, it's only 10% at 5-year overall survival, and none of the patient had a disease-free survival at the 3-year time point. That's the German database. And again, the overall survival of these patients depended on the PCI index, whether they were less than 6 or 7 to 15 or more than 16. That had a bearing on the overall survival, and also as depended on the completeness of the cytoreduction. CC0 and CC1 to 3 would have a bearing on the overall survival. The overall survival also depended on the center, and it was better in centers that were of high volume centers, which dealt with more than 20 cases per year. And this is a review of all the systemic therapies that are up till now available for patients with gastric cancer with peritoneal metastasis. It is very surprising that we know that gastric cancer is a common cancer, at least in some parts of the world, and particularly in India and in the eastern part of the world. And peritoneal metastasis is a very, very common phenomenon, and that's what we understood from the previous few slides. But what is surprising is that there has not been much focused work on the peritoneal metastasis subgroup of these patients. If you look at all the published recent studies within the last 10 years of systemic chemotherapy that were used in patients who had peritoneal metastasis, you would see that in all of them, the median survival time is very poor, 9 to 10 months. That's all you can see with the approach of systemic chemotherapy. And that too, these are publications within the last 10 years. And in patients wherein systemic chemotherapy and some sort of intraperitoneal therapy was done, again, over the last 10-year publication, you would see the median survival time is only between 15 to 22 months. More contemporary work that focused on patients with some form of intraperitoneal chemotherapy therapeutics are again cataloged here. one of the most outstanding work is from Dr. Yonemura, and we are very, very fortunate to have him here as our speaker. His work on 400 patients had a response rate of 64% and a median overall survival of 20 months in patients who had a CC0 at surgery and a very significant p-value. And this is a paper by Dr. Yamaguchi on the impact of pre-operative chemotherapy as initial treatment for advanced gastric cancer with peritoneal metastasis, either limited to positive peritoneal lavage or only localized peritoneal metastasis, that is P1A. And this is a multi-institutional retrospective study. Dr. Yamaguchi would state that about 700 patients, eligible patients, were looked at from a cohort of 800 plus patients, in which patients were randomized as initial surgery and initial chemotherapy. Initial chemotherapy was given in 150 patients. Initial surgery was in 500 plus patients. These were the chemotherapeutic regimens that were used. The most common ones were the cisplatin plus S1, and the second common was docetaxel, cisplatin, and S1. Let's see what is the result. The overall survival and the progression-free survival Kaplan-Meier curves were simply overlapping. There was no difference in the overall survival and the 5-year overall survival was very, very similar at 22 and 21 months for both upfront chemotherapy or upfront surgery. And only that in the initial chemotherapy group of patients, the DCS chemotherapy, particularly the docetaxel, cisplatin, and the S1, did much better than the others. That's all we could infer from the pre-operative chemotherapeutic approach. So let's look at what is available in the Hipec domain in these group of patients, gastric cancer patients with peritoneal metastasis. This is the work published by Dr. Glihan. And Dr. Glihan, this is one of the first large multi-institutional trial that had prospective data for patients who underwent cytoreduction followed by intraperitoneal chemotherapy with either Hipec, Epic, or both within the first 7 days of cytoreductive surgery. And you could see that the outcome depended on the completeness of cytoreduction, and it also depended on the peritoneal cancer index PCI. And again, Dr. Badgewell, who is considered as a pioneer of Hipec in the United States, again has published this year on the outcome of a phase 2 study that examined gastrectomy, cytoreduction followed by PIPAC, and in his hand, the overall survival was 22.1 months. These are some of the published studies that evaluated Hipec for patients with peritoneal metastasis as a therapeutic options, and we have cataloged all the work. And one of the outstanding work is again by Professor Yonemura, 83 patient, and in which he had used mitomycin, cisplatin, and each site, and he had shown a 5-year overall survival of 11%. And as Dr. Ajit Pai mentioned, now there is a lot of work that's happening on prophylaxis or preventive approach with Hipec in patients who had a locally advanced gastric cancer after curative surgery. And this is published by FAN in BMC Cancer in 2021. And this is their work on preventive Hipec. And the conclusion of that is preventive Hipec is possible and did not increase the postoperative complication. And it is safe and tolerable. But in FAN's work, it did not reduce the risk of peritoneal recurrence on the follow-up. This is another publication by Dr. Michael Ritovic, and this is on hyperthermic intraperitoneal chemotherapy as a prevention for metacutaneous deposits in patients. And this is a systematic review. Again, this has reviewed all the work that is done recently in the preventive domain. And once again, you would note that Dr. Yonemura is published on this in 2001, and 48 patients with 61%, I think that is a 1-year survival. And these are the sites at which the disease progresses after preventive Hipec, and the progression peritoneal dissemination is definitely lesser in patients who had received a preventive Hipec, and both metachronous peritoneal dissemination is 40% for patients who did not receive Hipec versus 16% who received Hipec as a prevention. but it did not control the distant metastasis in the liver or in the other site. And these are the other works that are published in the preventive domain. And the Dr. Yonemura's work is 48 patients who had surgery plus Hipec, and 47% who had only surgery, and 44 patients who had surgery plus Nipec and mitomycin cisplatin, and 5-year overall survival is 61%, 44%, and 42% for all these different options. Surgery alone is 42%. What about PIPAC? And we are going to hear from Dr. Reymond himself on the PIPAC, but I'm just summarizing the PIPAC, some PIPAC experience across the globe. This is a summary by Dr. Olivia on the current practice of PIPAC in this particular subset of patients. And this is a work done across multiple countries. And these are the regimens that were used for PIPAC: cisplatin and oxaliplatin, irinotecan, and in that work they have looked at the consensus rates for safety, installation, and technique. That was the publication, and these are the consensus rates that is published. And again, Dr. Aliami has published on PIPAC, and 42 patients, consecutive patients on PIPAC with cisplatin and doxorubicin, and another important work by Dr. Yonemura on the bidirectional chemotherapy for patients with peritoneal metastasis, and both systemic and intraperitoneal chemotherapy is combined. And this is NIPS included. Again, complete cytoreduction achieved at 70.7%. And switching gears, what about immunotherapy in this difficult subset of patients? There was some work published a few years ago by bispecific anti-EpCAM, but this study did not carry forward, and the long-term results are not exciting. But when we look at some contemporary studies with the currently available immunotherapeutic agents, this is the Checkmate 649 published in ESMO 2020 last year, in which first-line nivolumab with chemotherapy for advanced gastroesophageal and gastric cancer. In that, there was no separate outcome of patients who had peritoneal disease, but this is the load of patients with peritoneal disease, and in the nivolumab arm, peritoneal metastasis in 21% and chemotherapy arm 20%. But it will be interesting to look at the outcome in these patients, but we do not have separate outcome posted on these subset of patients. So it's very difficult to look at this subset of patients and look for specific outcomes with the currently available various therapeutic options, including systemic options, including immunotherapy. And therefore, we really need to look at what is the role of Hipec and PIPAC and other modalities that concentrate on the intraperitoneal approach. So that's what we're going to hear. This is another exciting work. I just wanted to finish off with this. This is the limb domain kinase inhibitor, and limb domain kinase 1, limb K1, is reported as a promoter of gastric peritoneal metastasis, and this could be a potential therapeutic target. Dabrafenib is one of the agents that can potentially target this. This is again transcriptomic work on the unique gene expression profiles on patients who would eventually develop peritoneal metastasis among the gastric cancer patients. And this is the LIMK1 knockout with the dabrafenib, which is a drug that we use for BRAF inhibition in our lung cancer. I mean, this is an exciting drug. It looks like this may be useful for LIMK1 knockout, and that may be a potential useful option in either treating or preventing patients with peritoneal metastasis. So in summary, these are currently the recommendations for the management of gastric cancer with peritoneal metastasis. There are not good systemic options, and therefore one has to look at how do we incorporate all the available approaches. Pre-operative laparoscopy is probably mandatory, and it's better to treat these patients in experienced center, and you need to have a multimodal approach. And patients with PCI score of less than 6 probably are potentially resectable. And these patients can be treated with pre-operative chemotherapy, something like a FLOT, and Hipec, NIPS, and EPIC should be considered in conjunction with multidisciplinary approach. And in patients who have an unresectable peritoneal metastasis, should preferably treated with systemic chemotherapy option. This is a proposed algorithm published by Dr. Kanbei in this year. And in patients who have either a positive cytology and ascites and peritoneal metastasis, you should have a multidisciplinary approach, and you should do a diagnostic laparoscopy and the laparoscopic Hipec, and followed by neoadjuvant intraperitoneal and systemic chemotherapy, possibly 3 to 4 cycles. And then you relap them, and then cytoreductive surgery, and followed by Hipec, and followed by adjuvant intraperitoneal and systemic approach. This is the algorithm that is proposed, but I think this is something that I can only theoretically propose. But we are very, very eager to listen to what Professor Yonemura and Dr. Reymond would tell us, and we are keen to listen to them. Thank you, Dr. Ajit, for putting us together. Thank you for this opportunity.
Thank you, Dr. Raja, for summarizing the current evidence for systemic therapy. I'm sure we'll have a lot of questions, but we'll take them at the end, I think, after the other two speakers have also spoken, so we get an overall view of the field. So I just invite my colleague, Dr. Naveen Padmanabhan, to take the stage and introduce Dr. Yonemura. So Naveen has been instrumental in putting all the logistics and hard work to get this meeting off the ground. And Naveen worked with Dr. Yonemura on a UICC fellowship last year. So that's where he brought back all the expertise which we are able to now perform here. So Naveen.
Thank you. Thank you, sir, for the opportunity. I will first like to thank Dr. Yonemura for accepting our invitation and joining us. So Dr. Yonemura is the chief of the peritoneal surface department at Kishiwada Tokushukai Hospital at Osaka, Japan. So he's been involved in treating peritoneal metastasis from 1980s. So to be exact, from 1985. I had the opportunity to train with him in 2020, last year, for 3 months. So I had the first-hand experience of the history of Hipec and cytoreductive treatment in Japan. So he was trained in Kanazawa University, where the cytoreductive surgery and Hipec originated. So he started treating patients exactly at 1988. And since then, he has been treating around 200 to 300 patients per year. So he treats peritoneal metastasis of colorectal, appendicular carcinomas, pseudomyxoma peritoneae, ovarian cancers, and gastric cancers. So as you know, the Japan is the most commonest cancer is gastric cancer. So he treats around 100 to 200 patients per year. So in 2005, he introduced a novel method, NIPS, that is the neoadjuvant chemotherapy, intraperitoneal chemotherapy with systemic therapy. So since then, he has published his experience all over, and he has also had a randomized trial published in Annals of Surgical Oncology in 2002, where his experience with surgery and surgery alone and surgery with Hipec combined, and he found he reported very impressive results. So since then, he has reported around 20 to 25 months survival with his novel method. So currently, he is about treating around 400 patients per year, and at least 100 patients per year of gastric cancer each year. So we would like to hear from him the extensive experience and his 3-decade experience from Dr. Yonemura himself. So over to you, Dr. Yonemura. Dr. Yonemura, your presentation is on. You can start presenting.
Okay, can you see here?
Yeah, we can hear you. Maybe you can increase the volume of your mic.
All right, thank you. Today I want to talk about factors related to the cure patients with peritoneal metastasis from gastric cancer by our comprehensive treatment. I can't move the next slide.
So
Okay.
we'll use the slides for you.
Okay. This is our comprehensive treatment. The treatment options used for comprehensive treatment are different from disease to disease. As you know, the gastric cancer biological behavior is very hard. So we choose 7 treatment options for the treatment of peritoneal metastasis from gastric cancer. First is the laparoscopic Hipec and NIPS, and the selection of patients for the candidate, to select the candidates for cytoreductive surgery. And we operate patients by cytoreductive surgery. Before cytoreductive surgery, we perform the extensive intraperitoneal lavage. And then after cytoreductive surgery, we start intraoperative Hipec using taxotere, cisplatinum. And then in some patients, we start early postoperative intraperitoneal chemotherapy. And all patients receive late postoperative chemotherapy. Next. Can't move. Okay. Concept of comprehensive treatment with intent of cure have 2 concepts. One is complete removal macroscopic peritoneal metastasis by peritonectomy. Second is eradication of micrometastasis by perioperative chemotherapy.
Dr. Yonemura, we will move the slides. So just tell us next slide, and we will keep doing it for you.
There are 4 processes in the treatment of peritoneal metastasis treatment. Course B and C shows the course of cure. If the patient's micrometastasis is less than the levels which can be completely eradicated by Hipec or postoperative chemotherapy, patient will be cured. But the patient may have the larger number of micrometastasis which cannot be eradicated by Hipec. If the patient received NIPS and the micrometastasis is reduced into the levels which can be completely eradicated by Hipec, may be cured. This is a course C. However, showing course A and D, patients will die even if we performed complete cytoreduction or intraoperative Hipec, because the micrometastasis outside the surgical field is larger than the levels which can be completely eradicated by Hipec or postoperative chemotherapy. Next slide. This slide shows our 842 gastric cancer patients peritoneal metastasis treated during the last 15 years. And patients received no neoadjuvant chemotherapy. Complete side reduction rate is very low. And also systemic chemotherapy, CCR resection is also low, about 44%. However, patients received NIPS or laparoscopic Hipec show the very high complete side reduction rate from 63 to 91%. From this slide, I believe that intraperitoneal chemotherapy is very important for performing complete site reduction. This slide shows the 20 patients who are supposed to be cured by comprehensive treatment, because these 20 patients survived without recurrence 5 years after comprehensive treatment. All these patients treated by complete cyto reduction and received neoadjuvant chemotherapy, and almost all showed cytology negative after neoadjuvant intraperitoneal chemotherapy. And this is the clinical factors of 20 patients cured by comprehensive treatment. All patients, the PCI level less than 10, and NIP cycle is about 5 to 14 times. A small bowel PCI less than 4, and number of resected organs less than 8, and number of resected peritoneal sectors less than 9. And serum CA and CA99 levels less than 7.8 and 96. This slide shows the survival effect of survival by neoadjuvant chemotherapy. You can see no neoadjuvant chemotherapy group patients all died within 10 years due to peritoneal carcinomatosis. In contrast, patients treated with intraperitoneal neoadjuvant chemotherapy, 10-year survival rate is 7.4%. And this is significantly higher than the no neoadjuvant chemotherapy group. In contrast, IV NACT also shows 10-year survival rate of 4.9%. We usually performed laparoscopic Hipec before starting NIPS. In this case, received the laparoscopic Hipec using docetaxel 40 mg and CDDP 40 mg, 43 centigrade, 60 minutes. Then I will show you the effect of laparoscopic Hipec. Before the effect of the laparoscopic Hipec, I want to show the thermal doses. Thermal doses are defined by temperature factors. And this was reported by Professor Saparetto, 1984. This is our criteria. One thermal dose, 30 minutes, refers to the thermal unit treated cells by 43 centigrade hyperthermia for 30 minutes. You can see here, if the intraperitoneal cavity was heated 43 centigrade for 30 minutes, total thermal doses reached to 30. In the Paradise 7 studies, they treated Hipec for 42 centigrade for 30 minutes. At that condition, the total thermal dose reached only 10. That is not enough to kill micrometastatic cancer cells completely. The upper table shows our actual data of patients treated by our high temperature Hipec. You can see the intraperitoneal temperature was treated by 42.9 centigrade to 43.5 centigrade for 40 minutes. And the total thermal dose of diagnosed pouch is over 30. And total thermal dose of subdiaphragmatic space is over 30. So I recommend the high temperature Hipec is very important to kill the residual micrometastasis completely. However, as shown in the lower tables, if we treat patients by 41 to 42 centigrade hyperthermia, the thermal dose is not enough to kill micrometastasis completely. So I recommend 43 high temperature hyperthermia. I'm sorry. Okay. This slide shows actual exploratory laparoscopy. You can see left upper half quarter shows the many cancer nodules in the right upper quadrant. After one cycle of laparoscopic Hipec, you can see right upper quadrant, you can see almost all cancer cells, peritoneal metastasis disappeared. Then we studied the effect of laparoscopic Hipec in 59 patients. First, we performed exploratory laparoscopy and counted the PCI and performed laparoscopic Hipec 43 centigrade 60 minutes using docetaxel CDDP. And 1 month after the laparoscopic Hipec, we again performed the laparoscopy or laparotomy to compare the changes of PCI. This is the next slide. Slide shows that after one cycle of laparoscopic Hipec, PCI mean reduction is 1.8. And also, positive cytology become negative in 58%. Accordingly, laparoscopic Hipec has a very high power to reduce PCI and cytological status. Then we studied the effect of 3 cycles of NIPS. NIPS is performing using the IP port. And we performed NIPS by using oral administration of TS1, 60 milligram per square meter for 14 days. And on day 1 and day 8, IPIV introduction of docetaxel CDDP, 30 milligram per square meter in each drugs. And this cycles repeated 3 times. And then we perform the laparotomy or laparoscopy. This is the result. You can see after 3 cycles of NIPS, you can see mean reduction of PCI is 2.3. And the positive cytology becomes negative in 79%. So the NIPS is also very effective to reduce the PCI and negative cytological status. Next slide. Then we studied laparoscopic Hipec plus 3 courses of DCS NIPS. And then 1 month later, we performed laparoscopy and compared PCI changes. Next slide. And this is a size after 1 cycle of laparoscopic Hipec plus 3 cycles of MIPS. We studied 104 patients. Mean reduction of PCI is 3.7. And negative cytology, positive cytology become to negative in 63%. Next slide, please. These results show that laparoscopic Hipec and NIPS is very effective to reduce PCI, and we can do the complete site reduction after these procedures. This slide shows the changes of lesion size scores of 13 peritoneal sectors after laparoscopic Hipec plus 3 cycle of NIPS. You can see, except 3 sectors of region 0, 4, 9, all the other 10 sectors, the lesion size score was significantly reduced after laparoscopic Hipec and 3 cycles of NIPS. The limiting factor to perform complete site reduction is the diffuse involvement of small bowel mesentery. So this method is very effective to reduce lesion size scores on the small bowel mesentery. All right, next slide. All right. Next, I will show you the effect of site reduction. This is a different survival of CCR0 and CCR1. You can see in complete site reduction cases, all died within 10 years after comprehensive treatment. In contrast, patients received CCR0 resection. 10-year survival is 6%. Next slide, please. And this is a survival difference according to the PCI level and small bowel PCI level. You can see the PCI higher than 11, all patients died due to peritoneal recurrence. And in addition, the small bowel PCI, less than 4, the 10-year survival rate is 8%. Accordingly, PCI and small bowel PCI is a key clinical factors for the favorable prognosis. Next slide. And this slide shows the survival curves according to the number of peritoneal sectors involved. If the peritoneal sector involvement was less than 4, 10-year survival rate is 7%. However, the peritoneal sector was involved larger than 5, all patients died of peritoneal metastasis. Next slide. This slide shows the prognostic factors after comprehensive treatment. Using Cox model, you can see post-neoadjuvant cytology, negative case, and number of involved sectors less than 4, PCI after NACT less than 10, histological effects is EF1B23 are the independent prognostic factor. after the comprehensive treatment. Next slide. This slide shows the 5-year survival after comprehensive treatment. When each peritoneal segment are involved, you can see here the patient's involvement in uterus, all died within 5 years. However, when the peritoneal sectors involved, the diaphragm or omentum pelvis or paracorid gutter, if we remove these peritoneal involvement sectors, we can get 5-year survival. So I recommend, if the tumors are involved on these peritoneal sector, we should remove the microscopic peritoneal metastasis. Next slide. From now, I will show you the effect of Hipec. After cytoreductive surgery, micrometastasis in the peritoneal cavity is least during the comprehensive treatment. So just after the cytoreductive surgery, is the best timing for Hipec to achieve complete eradication of micrometastasis. So we performed Hipec, intraoperative Hipec just after cytoreductive surgery. Next slide. This is an open type Hipec. And we never use cross type because of the cross type Hipec. We cannot obtain even heating of peritoneal sectors. We started RCT to confirm the effect of intraoperative Hipec in gastric cancer. Now, next slide. 10 years ago, the 266 gastric cancer patients with peritoneal metastasis was treated by DCS-IP chemotherapy 3 cycles, and 239 cases are eligible for the cytoreductive surgery by MRI or laparoscopic procedures. And these patients were divided into CRS plus EIPL alone and CRS plus EIPL plus Hipec. And these random studies was started 10 years ago. And this year, this trial was finished. And we analyzed the survival data. Next slide, please. This is the patient characteristics. There is no difference between two groups, non-Hipec and the Hipec group. Next slide. Non-Hipec group has a PCI of 8.1. Non-Hipec is also the same, except operation time. Hipec group significantly showed the long operation time. This is the post-operative complications. No. This is the clinical factors. Next slide, please. Hipec group has a significantly long operation time. And post-operative complication is relatively higher in Hipec group, but there is no significant difference between grade 3, 4, 5 complication rate between the two groups. Next slide. Survival is shown here. No Hipec group, significantly poorer prognosis than Hipec group. From these results, we believe the Hipec is very effective. High temperature Hipec is very effective for the eradication of micrometastasis. Next slide, please. Conclusions. 20 patients were cured by comprehensive treatment. Cured patients were characterized by CC0, treated with IP neoadjuvant chemotherapy. Post-NAC CY0, PCI less than 10, small bowel PCI less than 4. Neoadjuvant Hipec plus minus NIPS are the essential pre-treatment options to reduce micrometastasis on the peritoneal surface after cytoreductive surgery. Ultimate end of the surgical treatment is to achieve complete resection microscopic peritoneal metastasis in every peritoneal sectors. Residual micrometastasis should be eradicated by intraoperative Hipec. Next slide, please. This is the last slide. Patients satisfied these clinical factors should be treated by complete cytoreductive surgery plus Hipec. PCI less than 10, small bowel PCI less than 4. No macroscopic, number of macroscopic peritoneal sectors less than 4, and cytology negative after NIPS. These patients are recommended to perform peritonectomy and intraoperative Hipec. Thank you very much.
Thank you very much, Professor Yonemura, for your fascinating talk, the journey over the last 3 decades. I'm sure we'll have a lot of questions for you, which we'll take at the end of Dr. Reymond's talk. And then we'll have obviously a panel discussion where we'll flesh out the things. So now invite Dr. Marc Reymond to the stage. So Dr. Marc Reymond is a legend, so needs no introduction. But for the record, he is a professor of surgery and the director of the National Center for Pleura and the Peritoneum at the University of Tubingen in Germany. He's a cancer surgeon with extensive experience in the management of peritoneal surface cancers. He's also the inventor of the pressurized intraperitoneal aerosol chemotherapy PIPAC and the Secretary General of the International Society for Study of Pleura and Peritoneum. He edits and is the editor-in-chief of the peer-reviewed journal Pleura and Peritoneum. He has trained many surgeons, including me, in the techniques of PIPAC and safe entry into the operated abdomen. So Dr. Reymond, the stage is yours. We are all ears for your seminal talk.
So thank you so much, Dr. Pai, for the invitation. If there is a legend today on stage, it's not me, it's Dr. Yonemura. It's very clear. You know, I'm compared to Dr. Yonemura, I'm a baby in the scene, and I have a lot of admiration for the huge work done by Dr. Yonemura, but also all the Japanese colleagues on intraperitoneal chemotherapy, which is just a fantastic pioneer job they did since, well, 30 years at least. And I was also very impressed by the talk of Dr. Raja. Dr. Raja showed that he was open to combined approaches, and I personally believe that's the future. The best way to improve the prognosis of the patient with peritoneal mets is to work together, medical oncologists, immunologists, and surgeons, knowing that many medical oncologists have never seen a peritoneal carcinomatosis in the operating room. and that almost all surgeons have never understood anything from immune system and immunotherapy. So we just need to work together to highlight different aspects of difficult challenge for the patients and be able to work together. So I'm so happy always, every time I'm allowed to meet an oncologist who just want to make science-based translational research to improve the prognosis of these patients. So important. So thank you, Dr. Raja, for that. So I've been asked to talk about PIPAC indeed. So I will do so, but believe me, in the meantime, my interest is more on the rationale beyond PIPAC, what is happening in the peritoneal cavity, how peritoneal metastasis develop. And I know Dr. Yonemura has also did a similar way, going from Hipec to, let's say, perhaps not basic science, but translational research, looking at the peritoneum, at injuries in the peritoneum, of the way of direct or indirect or trans mesothelial implantation of peritoneal metastasis. And it's perfectly impossible to improve the therapy of this patient without a true translational approach, starting with the comprehension of the organ, of the disease, identifying targets, then formulating therapeutic substances, doing phase 1, phase 2, and phase 3 trials. And please, in this sequence, and not starting with phase 3, because if we do so, we had some example recently also in the scene of Hipec. It's possible that 10 years work just result in the negative results. So I'm allowed to change a little bit the title. So I wrote West meets East and not East meets West. And indeed, you can think it's very different. But in fact, there are many similarities. So I'm Swiss, and that's a typical Swiss co in front of the Matterhorn. And the first time I went to Bengaluru, so that's what I saw. So you see that even though there are many, many kilometers between our countries and the patients and the way we treat the patients, there are also many, many similarities. And I'm happy to share our experience with you, and in particular to learn from your experience. So I have some disclosure to make as the founder of, or the inventor of PIPAC and the founder of Capnomed. I'm also working with other companies to develop this therapy to transform ideas of doctors into a reality for patients. And the story of PIPAC is not so old. It starts pretty exactly 10 years ago in Bielefeld, where I performed the first PIPAC together with Marc from Paris. So it's always forgotten, but he was also there. And we treated the first patients worldwide. Now we are 10 years later, and I would like to propose to you 7 questions today. The first one, what is the level of evidence of PIPAC in peritoneal metastasis of gastric cancer? Second, what is the place of PIPAC for isolated peritoneal metastasis of gastric cancer in the upfront situation? Third, what is the place of PIPAC in the salvage situation, meaning second line and beyond? Fourth question, does PIPAC enable individualized therapy in peritoneal metastasis of gastric cancer? And here, Dr. Raja, I suppose, will be very happy of this part of my presentation. Fifth, because we are looking in the real world, could PIPAC be cost effective? Sixth, has PIPAC a role as a neoadjuvant therapy in peritoneal metastasis of gastric cancer? And 7, is there an option for PIPAC to be curative in these patients? So a lot of work, 7 questions, and I will answer these in about 20 minutes. So what is the level of evidence of PIPAC in gastric cancer? So first, perhaps useful to remember the levels of evidence because there are several scales. So I will use the Oxford scale, And as you can see, only randomized trial can bring an evidence level of 2 or 1. Everything else is between 3 and 5. 4 is in surgery the most common case series, case control studies or historical controls, and level 3 is non-randomized but ICH GCP control clinical trials. So what are the published or presented or completed studies on PIPAC in peritoneal metastasis of gastric cancer? So there are 11 studies, and you see that the Oxford evidence level remains low, all of them being evidence level 4 and 1 being evidence level 3 in the salvage situation. You see here that many studies combine PIPAC with systemic chemotherapy, so-called bidirectional chemotherapy. And you see here, for example, a true, our German study was a true ICH GCP study, but many of these studies are just prospective or even retrospective patient cohorts. So is the situation going to improve in the next year? The answer is hopefully yes. In particular, because of 2 studies, one in France, which is the randomized phase 2 trial nationwide, coordinated by Clarisse Evenot, Professor Clarisse Evenot from Lille in France. So they want to include 94 patients. The good news, I spoke with her in Paris at the beginning of July. They have already included half of the patients, so they recruit very well. So they compare systemic chemo alone against systemic chemo plus PIPAC with cisplatin doxorubicin in patients with peritoneal metastasis of gastric cancer with a PCI superior to 6. And the results are brought 224, but I think we can correct now. We'll get the first results in 2023. Now there's a huge randomized trial in Russia in the adjuvant situation. So they combine PIPAC with gastrectomy. They want to include 304 patients. These would deliver a level of evidence 1B. They have started the trial, and don't underestimate the Russian centers. That's the Pavlov University in St. Petersburg, and together with the Herzen Institute of in Moscow. These are tertiary center with a huge patient recruitment, outstanding quality. I've been there. It's impressive, and they are doing an outstanding job. They were also the second team worldwide to start with PIPAC, and they will probably be the first team bringing evidence level 1 in PIPAC also. So I'm very thankful to our Russian colleague for their pioneership and their support in developing this new therapy. So now the second question: what is the place of PIPAC for isolated peritoneal mets of gastric origin in the upfront situation? So what is the best evidence available? Again, provided by a Russian team from Moscow, Vladimir Komyakov, my good friend. Basically, it's a propensity score analysis between 2 groups, the groups treated with systemic chemo alone, and the second group treated with systemic chemo, double or triple chemotherapy, plus PIPAC. The interesting setting is that the indication to be included in the one or the other group was not a medical indication. It was just the availability of the device to perform PIPAC, because at that time there was no approved device for PIPAC in Russia, so it was very difficult to import these devices. So members of patient families had to come to Germany to pick up some device and so on. So some patients received the device and others not, and those who received the device received PIPAC. And if you look at the groups, they are pretty similar. In fact, the ECOG is superior, meaning the patient in the group with combined therapy had a better general condition than the patient treated with, the patient treated with systemic chemotherapy had a better general condition as the patient treated with combined therapy, systemic chemotherapy plus PIPAC. So the results are impressive with a hazard ratio for death adjusted of 39.6%, meaning that the risk of death for the patient treated with additional PIPAC was only 39 or 40% of those patients treated with systemic chemo alone. And this reflects also in the median survival, indeed, with 7 months in the systemic chemo group alone, which matched what we expect from the literature after chemo alone. And the combined group doubled. And since the patients were not in so good after adjusted, so the hazard ratio is even better than 50%. And the second interesting observation is that you see that there are a subgroup of patients who receive combined therapy which are still alive after more than 18 months. I can tell you they were not in the study, but we have now first survivors of non-resectable primary non-resectable peritoneal metastasis of gastric origin, which are alive 7 years after first PIPAC. So yes, they are long-term survivors. This patient received secondary gastrectomy and Hipec. Now, if we just look at the other studies, there are two. The study from Beate Rau, we just spoke before about for the Gastric study. So Beate and Andreas Brandl have compared their cases treated with PIPAC and chemo versus the patient that treated just before only with chemo. And you see here again that the combined therapy group had double survival around 17 months as compared to the chemotherapy alone, who was around 7 months, like in the series of Komyakov. And then the group of Lyon from Olivier Glenn and Mohammed Aliami, this just a single group. They treated all patients with systemic chemo plus PIPAC CD. They have a median survival of 19.1 months, 42 patients in their prospective registry. So this data is reproducible, obviously, between 3 different centers. So it looks like that the survival after systemic chemotherapy plus PIPAC might be superior to systemic chemotherapy alone, and the order of magnitude might be it doubles. The confirmation is expected, as I said again before, with the randomized trial in France in about 18 months from now. So the third question, what is the place of PIPAC in the salvage situation, meaning second line or later? So there are 3 studies in the literature. And so first, interesting, you have no mortality in no one of the studies, a low rate of CTCR of severe complications, a high rate of histological response. In our study, so we distinguish between ITT and PP. So you need indeed at least 2 PIPAC to make repeated biopsies and to assess a histological response using the PRGS. So that's the reason why you have a huge difference between ITT and per protocol. And in our study, we had a radiological response, intention to treat in 40% of the patient. The others didn't make an assessment according to RECIST criteria. You see that the survival is poor, but the quality of life of the patients appears preserved. And this is one of the patient of our study where you see at the beginning of the therapy in the salvage situation, multi-peritoneal metastasis, presence of ascites and a retraction of the mesenterium, which is all bad sign of prognosis. And you see after repeated PIPAC, the vanishing of the peritoneal mets and of ascites, and in fact, that's the only one, but this is a complete radiological response of signature cancer of the stomach in the salvage situation under PIPAC therapy alone. So this patient only received PIPAC, which is, you will agree with me, a pretty impressive picture. The fourth question, does PIPAC enable individualized therapy in gastric cancer? So as you know, the classical classification of gastric cancer is Lorraine, which distinguishes between two main types, and which also underlines that the signaturing histology is linked to poor prognosis with a frequent progression to peritoneal metastasis. More recently, 4 molecular subtypes of gastric cancer were defined: EB, so Epstein virus positive, microsatellite unstable, genomically stable, and chromosomally unstable. These subtypes probably have therapeutic consequences, in particular concerning immunotherapy. But in general, what we can say is that gastric cancer harbors many redundant oncologic pathways, so it's pretty difficult to treat this tumor by targeting only one pathway, and that's indeed an obstacle for targeted therapies, and it's a reason to use multimodal or combined approaches, and that's what's happening now in Europe with, for example, FLOT, which is multiple chemotherapy, but also starting now with the combination of systemic immunotherapy and chemotherapy, or of systemic immunotherapy and PIPAC. There is a trial running in Singapore looking at this. So there are now data showing that the mutational profile of the peritoneal metastasis differ from the primary tumor. There are frequent CDH1 and TF1 mutations, and there are also chromosomal loss and gains in the peritoneal metastasis. And all gastric cancer do not behave the same, and aggressive gastric cancer have well-defined phenotypes relating to increased mutations in TP53, CDH1, which is an adhesion molecule, TEF1, KMT2C, a higher level of clock-like mutation signature, an increase in whole genome doublings, so 2 or 4N, chromosomal instability, in particular the number of copy losses, a reprogrammed microenvironment, enriched cell cycle pathway, and MYC activation, resulting in an impaired immune response, which is perhaps the reason why systemic immunotherapy only works in the minority, in fact, a small minority of gastric cancer patients. So these molecular subtypes are relevant for therapy, since you can predict treatment response with these profiles. The epithelial subtype, or in fact intestinal-like type-like, if you refer to Lorraine, has a good response to systemic chemotherapy with 71%. Whereas the mesenchymal subtype, which is diffuse type-like, referring to Lorraine, has a much lower response to systemic chemotherapy. But these patients are potential candidates for immune therapy, and there are several targets that could be addressed in these group of patients with the mesenchymal subtype. So, which mutations are relevant in clinical practice? So at the University of Tubingen, for our molecular tumor board, they ask for a complete coding sequence of CDH1 and SMAD4, and a sequence of the hotspots region of a series of well-known tumor associated genes, including KRAS, PRF, TP53, and others. PIK3, for example, which is now also a very hot topic in medical oncology research. So, how do you want to profile peritoneal metastases without biopsies? It's impossible. So therefore, you need a laparoscopy, and that's the first reason for an increasing role of laparoscopy in peritoneal metastases of gastric cancer. And this is very evident in Asia, and it's getting more and more in Europe also. So assessing therapy response in peritoneal metastasis is difficult. It's a challenge. The application of radiological criteria according to RECIST 1.1 are truly challenging, in particular for small molecular peritoneal metastases. ASITE is not recognized as a response criteria, etc. And that's a second reason for an increasing role of laparoscopy and integration of laparoscopy into therapeutic algorithms. You remember that Dr. Yonemura showed us how the PCI response under NIPS therapy, and indeed with PIPAC, since we do laparoscopy anyway, in contrast to NIPS, then we see that in real time. So there is a need for a widely accepted standard, this standard to assess therapy response of peritoneal metastases. There was no such standard, so Wiebke Zolas and a group of European pathologists proposed such objective histological tumor response grading system. And in the meantime, they did a lot of work on this score, validating the reproducibility, the minimal number of biopsies, the role of additional staining, and recently the prognostic scores. Some of these papers are already published, others are in review. But the PRGS is obviously more and more accepted as a standard worldwide. If you have biopsy, you can not only look at the histological tumor response, you can also look at gene expression over the course of therapy. This has been done, proof of feasibility in ovarian cancer, not in gastric cancer. And as you can see here, you can define subgroups of patients with more or less positive prognosis depending on modification of gene expression under therapy. That's indeed the third reason to integrate laparoscopy and biopsies into therapeutic algorithms. And these allow an adaptation of therapy in real time, depending on the repeated biopsies. So it starts with a staging laparoscopy with PIPAC in the presence of peritoneal mets, and you can take biopsies and you can make an initial PRGS. It looks like that in the salvage situation, the patient who have a PRGS 1 or 2, meaning no tumor cells or only isolated tumor cell, have a better prognosis than the others, which is logical. It's probably the selection of the patient who responded to systemic chemotherapy. So you can you can sequence the peritoneal metastases looking of addressable mutations, but you can also make a first gene expression profile as a reference for later measurements. Then the patient receives systemic chemotherapy for 6 weeks, and then comes to the second staging laparoscopy. We make again a PRGS. We look if there is a histological response. We can profile gene expression, and then you can define good responders. Those are candidates for cytoreductive surgery, possibly also Hipec, and bad responders, but who will not benefit of cytoreductive surgery. But for those, you can individualize chemotherapy because you know objectively if they have responses, and you know that in a very short term, meaning already after 6 weeks. Then you repeat these, and possibly you can make cytoreductive surgery after the third PIPAC, etc. So we call that the Tubingen algorithm, and we are currently in the process of implementing that in clinical practice. So could PIPAC be a cost-effective treatment? So there is one publication published last year as ASCO GI, which is now in review in an oncology journal. So the two groups were defined. The first one, the patient in the upfront therapy situation, and the second group, the patient in the salvage situation. And you see here what was the comparator used. These are the data used for as a database, including the best available evidence with ramucirumab in the control arm. And you see in the upfront situation a better survival after PIPAC and chemo than after chemo alone. And in the salvage situation, the same. Now, indeed, the median survival is relevant. So you see that on the basis of, it's about 100 simulations, you have almost a doubling of the survival in the upfront situation, and in the salvage situation is less, but there is a better survival. And then when you look at the cost of the procedure and you balance the cost with the additional survival, then you can see that in the upfront situation, where in the PIPAC group, the patient also receives systemic chemotherapy. So the cost of systemic chemotherapy are there in both groups, and there are additional costs in the PIPAC group. Then in about 1/3 of the patient, the combination therapy was cost effective according to UK criteria. And in the salvage situation, where it was in one group systemic chemo alone, and in the other group PIPAC CD alone, then PIPAC is better and cheaper. So in this case, in almost all the cases, PIPAC was a so-called dominant strategy, meaning less costly and more effective than the comparator. So has PIPAC arose as a neoadjuvant therapy in peritoneal metastasis of gastric cancer? So from the data I presented, you can already know the answer. So there are 4 sources of data: our phase 2 trial, then the Italian group, then the group from Leipzig, and the French prospective cohort. And you see that the answer is yes, in 3 to 14%, with I mean, if you calculate on the total number of patients, let's say about 1 out of 10 patients with non-resectable peritoneal metastasis of gastric cancer can be converted into a resectable case after combined systemic chemo, or in our case, there were 2 patients who received only PIPAC CD and became candidate for cytoreductive surgery. So this leads us to the next question. Could PIPAC be curative in gastric cancer? So if you look now again at the study of Komyakov, but also at the study of Aliami, obviously there are about 1/4 of the patient, 20%, 25%, who survive more than 2 years. And this is something very new in peritoneal metastasis of gastric origin, where with systemic chemotherapy at that point of time, all patients are dead, and reports of long-term survival are exceptional, if any. So we come to the conclusions. So first, at the present point of time, PIPAC does not deliver Oxford level evidence higher than 3. We have no randomized data which are available. That's normal, dear colleagues, in a new therapy. It takes time to provide randomized data. And as I told you before, we expect the first data in 18 months. In the upfront situation, PIPAC with cisplatin dexamethasone is feasible and safe, does not impair quality of life. Survival data are encouraging. Comparative data based on propensity score are available. A phase 2 trial randomized is recruiting in France. And I told you results expected relatively soon. In the adjuvant situation, so I've wrote that associating PIPAC with gastrectomy is not recommended so far because of the risk of anatomic leakage. However, at least 3 centers are evaluating this approach under study condition. A phase 3 randomized trial is recruiting in Russia. Results expected in about 5 years from now. So, which is interesting is obviously that there is now more and more centers in the PIPAC community who start to combine gastrectomy with PIPAC. So that's very new. We had a webinar in June on this topic, an ICSP webinar. So certainly do not start with that when you start with the PIPAC program, but the people who are doing that have so far good experience. In the salvage situation, PIPAC with cisplatin doxorubicin is feasible in the majority of patients, well tolerated and safe, does not impair quality of life, induce an objective histological regression in the majority of patients. So that are encouraging, but there are no comparative data available, so Oxford level 4. Cost effectiveness, PIPAC CD is probably a cost-effective situation in the salvage situation if used alone, and might be cost-effective in the upfront situation depending on the drugs used and the conditions, the cost of the OP, etc. In the neoadjuvant indication, PIPAC with doxorubicin can obviously convert about 10% of non-resectable peritoneal metastasis of gastric cancer to a resectable disease. And there are some long, but several, and in several centers, long-term survivors, 5 years and more, with initially non-resectable peritoneal gastric cancer. That's very good news in a therapy which is not optimized and where most not formulated properly and where most parameters were arbitrary. So we expect this percentage to improve with further development of the therapy. So I didn't, that's the end, but before I stop, I would like to invite you to become member of ISSPP. Unfortunately, the disease and peritoneal metastasis in particular, that's also true for COVID, do not stop at national frontiers. You can even try to close the border, but this will not prevent diffusion of disease. Fortunately, the wish of physicians to collaborate to fight against disease does not stop either at national borders. And ISSPP is an organization, non-profit organization, aimed at improving the patient's prognosis. And we are on the right way to do that. And we have outstanding actions from top people worldwide, not only surgeons doing Hipec or PIPAC or whatsoever, but immunologists, basic researchers, thoracic surgeons, immunologists, and so on. So that's a very good platform to progress together against this disease. And very specifically, I would like to invite you to ISSP Congress, which will be, it's confirmed since the beginning of July. We have enough inscription. Yes, there will be an on-site Congress in Rome at the beginning of October, but for you, in particular for India, you can also participate online. There is a virtual access to the Congress with a lot of topics dedicated to gastric cancer, not only, but there are several topics related to gastric cancer. So you are most welcome to participate to this Congress. Thank you for your attention. I'm ready for your questions.
Thank you very much, Professor Reymond, for a fascinating talk. I think all of us had several questions, but you seem to have nullified all our questions with your very methodical assessment of all the possible queries one would have with PIPAC and concerns. Also, I think you enthused younger people in the audience to take up PIPAC seriously. So we have, I think, a couple of questions from the audience, but I would expect more people to join the chat and we can have a brief discussion before we move on to a panel discussion where we will flesh out all that has been spoken. So the question I have for Dr. Reymond, which is also put by one of the audiences, you're speaking about PIPAC, and Professor Yonemura, to you also, you're speaking about lab HIPEC. So lab HIPEC is something which can be easily done with the conventional resources, which is you have a HIPEC machine, you have laparoscopy, you can run lab HIPEC. HIPEC, of course, is slightly more resource intensive because you have to anticipate the need and have the cap open. You need to have a CT injector, which may not be readily available. So how would you compare HIPEC with lab HIPEC? Should we have a trial to compare the two, or is there enough evidence to say that PIPAC is better than lab HIPEC?
So at the present of time, there is no comparison. So what we know is that pressure increases drug uptake into the tissue by convection. I think that's well established in the meantime. So there is a clear advantage of applying a drug into the perit cavity under pressure. And when you do lab HIPEC, you use pressure. When you do PIPAC, you use pressure. So, and about the same pressure. So probably the influence of pressure is the same with both procedures. Now, the good news with the aerosol is that an aerosol has no shape and no volume. So a liquid has no shape but has a volume, and a solid has a shape and a volume. So in theory, you have a better homogeneity or spatial distribution of an aerosol as compared to a liquid, and a liquid as compared to a solid. So in theory, pharmacologically, PIPAC is superior to laparoscopic HIPEC, but this has not been proven. There is one study in the pig, but this study has in fact flaws because the probes were not dried. So you understand what I mean? So if you have a tissue biopsy and you don't remove the liquid on the surface, then indeed you will measure the liquid film with the probe, but that's from the pharmacological point of view not acceptable, because you are interested in the concentration of the drug in the tissue, not on the surface of the tissue.
Professor Yonemura.
And this study showed, in fact, that PIPAC performed better in the, I think it was the visceral peritoneum, with 1/5 of the dose of HIPEC. But it's big, so we have to be extremely careful about any conclusion. So we are evidence level 5.
So Dr. Yonemura, Professor Yonemura, would you be somebody who would take up PIPAC?
Yes, I have no experience of PIPAC, but in HIPEC, the penetration distance of drugs from peritoneal surface are reported about 2.5 millimeter from the peritoneal surface. My question to the PIPAC is that how about the penetration distance drugs?
So we looked at that, and the answer is clear. So you have a much deeper depth of tissue penetration after PIPAC than HIPEC, as long as you don't increase pressure. And this is very well documented experimentally. So there's no question about that. That's a scientific fact, which is found also by Sugar-Baker, by the way. Jacquet published on the influence of pressure, both on tissue penetration and concentration. And then there are at least 10 experimental studies confirming that. And now there are also arguments in ovarian cancer showing the same. So I think that's clear. So the pharmacology of PIPAC is superior to Hipec end of line.
Dr. Ajit, I have a question here, if you permit me, to both our very illustrious speakers. One of the basic differences between Hipec and the PIPAC is that Hipec also employs heated. It's a high temperature risk. So what has got temperature got to do with the pharmacodynamics here? And PIPAC, as he pointed out, is a pressurized aerosol with the homogeneity, but Hipec has got temperature as another. So, we have seen, at least in intraarterial therapies, particularly in the sarcoma domain, that temperature has got something to do with that. Melanoma, again, we know that temperature has got something to do with although loco-regional therapeutic options. So therefore, here in PIPAC, there is no control, or there is no control over the temperature, or there is no dedicated higher temperature setting, so on and so forth. So what would that difference mean here? Thank you, sir.
So I think there are two parts of my answer. The first one is related on the evidence of the additional benefit of hyperthermia in Hipec. So there are two additional benefits. The first one is pharmacological. The second one is biological, heat shock proteins, immunogenicity, etc. So there is a very strong experimental rationale for hyperthermia in Hipec, but the clinical evidence supporting the additional clinical benefit of hyperthermia is not given. So it's just not, in the human patient, it's not proven. However, I was also very fond of bringing hyperthermia into the PIPAC concept. So perhaps you know that Professor Kim from Seoul published the first device in 2016, I think, and did an experiment of the pig showing the feasibility of hypertherming PIPAC with low hyperthermia. So he was between 38 and 41 degrees, so perhaps not high enough, but it was feasible and safe. The problem was that the devices were so huge and complicated that obviously it was not possible to certify, and it was not also possible to implement that in the clinical routine. So we developed an alternative, simple method for hyperthermic PIPAC. You have seen my disclosure. So this was together with Fisher Paykel Healthcare from New Zealand. They boosted their Humigard, which is a warm device, warming up and humidifying CO2. So we improved the energy output of this device, and we tested this in ex vivo in a model with thermal inertia. So the answer, it needs a lot of energy. So we had to add an additional device with infrared heating. We had to warm up the chemotherapy, but then we were able to maintain the tissue, not the gas, the tissue, the peritoneal tissue, at a temperature between 41 and 43 degrees for about 30 minutes, which is enough in theory. And then we perform pharmacological experiments. So these will be presented at the Rome Congress. This new data, it's not published. But unfortunately, the pharmacological data, meaning the tissue concentration of cisplatin and doxorubicin, were lower for hyperthermia than for normothermia. The explanation is that due to the fact that we need warm, humid CO2 to warm up the target tissue, we already impregnate the tissue with liquid. So we already make convection in the warming up phase, okay? So that the tissue is, in quotes, occupied by the warm liquid, and this offers a resistance to drug uptake. So in our hands with this technology, it did work from the pharmacological point of view. On the biological point of view, we can say nothing because so far we did not test it. So let's say like that. In my lab, and we do a lot of experiments for 5 years on intraperitoneal drug delivery. So hyperthermic PIPAC is not one of the top competitors for the future. Electrostatic precipitation PIPAC is much more effective than PIPAC. So it's probably the development will go into the direction of ePIPAC and not HPIPAC. But I don't know anything about the future. But as of today, that's the state of science in my lab, and I think also in the lab of Wim Selen in Belgium, which is, I think, also leading in the field. So we agree on that, we both.
I have a question to Professor Yonemura. Professor, you have number of publications on. I have read all your work over the past week in preparation for my talk. I'm so impressed with what you have done over the past 3 decades. I think a big salute to you. I also read that you have also done, apart from Hipec, the conventional intraperitoneal chemotherapeutics have also been very strong. So you are well published on that. So my question, and there is a chat box question on that. How do we compare the normothermic intraperitoneal chemotherapeutics with Hipec, and whether Hipec can be used repetitively like what we do for the normal intraperitoneal chemotherapy? So how do we compare between these 2 options, and whether Hipec itself can be repeated safely over repeated junctions? So that's what I want to hear from you. Thank you, Professor.
Yeah. Regarding the Hipec, I recommend 43 centigrade is vital, because the theory of Arrhenius, 43 centigrade is essential to kill the cancer cells. So, and in European countries, Hipec is done only 42 to 41 centigrade. That is not enough to cure residual micrometastasis. So, we usually perform the high temperature Hipec, 43 centigrade. You can see in my slides, the thermal dose of 43 is significantly higher than the thermal dose of 42. So I want to perform the laparoscopic Hipec many times, but that was a limit for the times. And at least 2 times is maximum trial for laparoscopic Hipec. But laparoscopic Hipec plus NIPS has a very big role to reduce the micrometastasis in the peritoneal surface.
I would like to support that. So that's certainly a huge contribution of the Japanese colleague to have shown that you need to apply intraperitoneal chemotherapy repeatedly. Once is not enough. And if you talk with a medical oncologist, Dr. Raja will support that. There is no palliative chemotherapy you give just once. That does not exist on the systemic approach. So there is no reason to do it another way for the local regional approach.
Yeah.
I have a question for Dr. Reymond. My question is, have you combined IP chemotherapy using a port with Hipec? Because
No.
Dr. uses it with the lab Hipec. Have you tried? Have you compared?
No. But the future is, I believe, is another one. The future is PIPAC with delayed release drugs. So we'll just, well, we have already developed these formulations. It's just a question of time that they come to the OR.
So we have a panel discussion, but I think some more questions can be discussed. We have a lot of questions for Dr. Raja as well. but we'll put it in the panel discussion with an actual case. So with the permission of the faculty, we will move on to the panel discussion. I invite Dr. P.K. Reddy, who is Senior Surgical Gastroenterologist with the Apollo Main Hospitals. And he's a doyen in the field of surgery and has mentored many of us. I invite all the panelists, including the three eminent faculty, Dr. Ramakrishnan, Dr. Padmanabhan, Dr. Ajit, to join the panel. And I hand over the mic to Dr. P.K. Reddy to start the proceedings.
Ajit, thank you.
Thank you, sir.
Thank you very much for inviting me to participate in this wonderful program. And we're dealing with only one particular thing, that is peritoneal metastasis in gastric cancer. Wonderful. I really admired. And then every talk has been excellent, actually, including your overview of the gastric cancer in India and other parts of the country. And very nicely, of course, Raja has quoted a number of papers, which I read, all of them. I read it, actually. And plus, of course, you invited the doyens, that is Professor Yonemura, who has a 3 decades experience with Hipec, and Professor Reymond, who is the inventor of PIPAC. And we've given excellent talks about it, actually. If you just take 1 minute, and my association and Raja, we've been treating the gastric cancers for the last 2.5 decades, Dr. Raja, am I right? About 2.5 decades. And very interesting to see how the science has progressed. And during those days, once the peritoneal metastasis was there, that's it. The patient goes to Dr. Raja. So no more. Unless the patient has got an obstruction, we will not interfere with it. That was the concept. And Dr. Raja used to take over and treat them. And now, very interesting to know, and then all these new regimens have come, and we have to wait and see, because whatever I have read, most of the papers, whatever I listened to both the doyens in the field of this peritoneal diseases, I could see about 17 months longevity of life in these patients. And but very interesting to see. But however, the panel discussion, and I also thank Dr. Naveen for coordinating with me for the last few days. Now I invite the panelists, both the international experts, Professor Yonemura from Osaka and Professor Reymond from Tubingen, and my own colleagues, Dr. Professor Raja, who is our medical oncologist. I don't need to tell anything much because Ajit Pai has already mentioned. Jairaj Govindaraj, he is one of the excellent figures whom I've been associated from a long time, and excellent in the interventional procedures of the ultrasound, CT scan, and MRI. And then Professor and Dr. Ajit Poineer, I have not met him. Welcome, Dr. Poineer, National Oncology Center, Royal Hospital, Muscat, and Professor Ramakrishnan, Professor of Surgical Oncology from Adyar Cancer Institute, Chennai, which is one of the renowned cancer institutes in the world. I welcome you all, and I request Professor Ajit Pai to moderate the session. He has chosen a very nice case capsule, and he will be able to put it in a nice way so that all the audience, I request audience not to leave and listen to this. Each question he has made it so nicely so that you all will enjoy and learn a lot from it. Thank you. Ajit, to you.
Thank you, sir. I'll also invite Dr. Padmanabhan, who's medical.
I'm sorry, I forgot about Pirama. Just want to tell about Pirama. He's an interventional endoscopist, plus his main interest is an endoscopic ultrasound scan, which is very much useful in gastric malignancy as well. And he's a wonderful person, young, enthusiastic gastroenterologist. Thank you.
Thank you. So we'll start the panel. Today we have chosen one case from my unit. I think it's very complex and brings out the entire spectrum of what we have spoken. So we'll have ample time for discussion of this one case. I just kept it to one case because I thought when we have more cases, we run out of time. So this is a 45-year-old gentleman from Nigeria, a doctor by profession, who came with loss of appetite, early satiety, and pain abdomen. He was evaluated in Nigeria and Lagos and diagnosed to have adenocarcinoma of the stomach, the proximal stomach, and he came to a center for further management. Clinically, he has an excellent performance status, no comorbidities, no palpable mass, neck nodes, or ascites. An upper GI scopy performed by a medical gastroenterologist showed an ulcerated lesion in the cardia of the stomach, extending to about 6 centimeters below the G junction along the lesser curve. And a biopsy returned a primary diagnosis of poorly differentiated adenocarcinoma. My first question to Dr. Padmanabhan is, what additional modalities would you do when you do an upper GI scopy for gastric cancer? Just a plain simple scopy, or do you always combine an endo ultrasound? And what additional information do you hope to find?
Thanks, Dr. Ajit, for including me in this panel discussion. As far as this question goes, I mean, routinely right now, if it's in the current practice, what we do is to first stage it with a cross-sectional imaging, like a CT, or sometimes a PET CT, to see if there are any distant metastases. If it is not, so if it's only an early stage cancer, then we can go about looking at an endoscopic ultrasound, like if there are no significant nodes around, there's no liver mets, no ascites, no distant mets, then comes the role of an endoscopic ultrasound. It does give us good information about the depth of invasion of the malignancy, and also reasonably good at the nodal staging. Unfortunately, in India, most often what we see is actually advanced stage of gastric cancer. So what we really get to do in practice is, early gastric cancers are pretty less to come by. So the role of EUS in our current setting is pretty limited. Very, very, very few cases where we have early gastric cancers where you need to look at the depth of invasion and stage it better. Most often it is T3 or N2, where the decision about neoadjuvant chemo radio is already taken.
All right, thank you. So the tumor markers were essentially normal, and with the blood parameters, and the CT scan showed gastric thickening in the mid-gastric body and cardiac in the mid-body with reduced gastric distensibility. I'll hand it over to Dr. Jayaraj, a radiologist, and we'll just run the CT scan for all of us to have a look. This is the CT of the patient, a contrast-enhanced CT of the chest and abdomen.
Good evening, everybody, and thank you, Dr. Ajit, for inviting me to this wonderful talk, as well as to Dr. P.K. Reddy for an excellent introduction. So thank you all. And without this, we are going through the scans of the cross-sectional imaging here. And one can see over here, just in the epiphrenic area, a bit of a nodular mass, which is non-FDG avid. Actually, the FDG avidity is seen on the fusion images. As we come down, you can see some nodules in and around the...
You're not seeing the images, Dr. Ajit, only the slide is available.
Okay, you can't see the images?
No images right now.
1 second, let us just give us a second. Can you see it now?
No, not yet.
Okay.
Yeah, yes, it's good.
Okay, I'm sorry, we didn't realize we're not sharing the screen. Thank you.
What we are seeing here is cross-sectional imaging starting at the level of the chest. And I'm trying to scroll down. Okay, what happened? It's gone. Can you all see it now?
Yeah, you can see it now.
Yeah. So I'm starting at the region of the thoracic inlet, and you can see a large right paratracheal node over here, a huge one. And as we come down the chest, to come. It's a bit jumping over here, but anyway, you can see that there are some the thickening of the stomach, indicating the gastric mass along the lesser curvature and towards the cardiac end of the stomach, and the gastroesophageal junction as I evidenced over here. And around the stomach, you can see some nodules, which is probably some invasion into the perigastrium. And you can see over here some all of these lesions extending across the serosa and into the fat of the mesogastrium. As we come down, that's the duodenum over here, and the IVC. As we come down further, the evidence of peritoneal disease is really difficult to identify because the micrometastasis is a no-no. We're not able to tell it with confidence, but some nodularities along the peritoneum, slight thickenings here and there would indicate that there is evidence of peritoneal disease, diffuse peritoneal and mesenteric disease. So that would be the inference from the CT morphology. One can see the peritoneum over here, the parietal peritoneum, and a bit of nodularity around it. And that would tell us that there is evidence of small disseminated peritoneal metastatic disease.
Dr. Jairaj, is this your preferred imaging for stomach cancer, or do you often ask for a PET or an MRI? Do you use them to complement? So what should be our take home for imaging for carcinoma of the stomach?
In India, we are always looking at the cost effectiveness of everything. And it is important that we also keep the investigations to the bare minimum before the surgery. And CT, of course, CT provides everything. And the PET CT for larger metastatic disease, the remote metastasis, as Dr. Brahmanayagam told, that it's very evident when we do a PET CT and get the overall picture of the staging of gastric cancer.
Can I just ask, Ajit, can I just ask one question to Jairaj? Jairaj, how accurate is PET scan for detecting the peritoneal mets?
Thank you, sir, for that question. This has been often the ban of us. We are always asked by the clinicians to tell for definite whether there is PET evidence of peritoneal disease. Now, the FDG avidity is something that everybody knows about, but lesions that are smaller than 5 millimeters are difficult to pick up because the isotope that emits the FDG avidity doesn't have enough concentration to be picked up by the camera. The sensitivity of the camera is low. So we rely mostly on the CT morphology. And of course, if PET avidity is there, it indicates the aggressiveness of the lesion.
All right. So we'll just move on. So the ideal imaging would be a CT scan of the chest, thorax, and abdomen. And there is limited role for PET CT at this point.
Yes.
But the NCCN guidelines, I think, now suggest that PET CT should be routinely added to the imaging protocols. We'll ask Dr. Ramkrishnan. Ram, do you have a preference for imaging for gastric cancer, or do you go for a routine CT chest, abdomen, pelvis?
Thank you, Ajit. I hope I'm audible.
Yeah.
You are.
Thank you. So at the Cancer Institute, the only imaging we perform for a locally advanced gastric cancer would be a CT scan of the abdomen pelvis, contrast enhanced. Except in case of probably a Sieverts 2 OG junction adenocarcinoma, we probably may ask for a PET scan. We do not perform a CT scan of the chest as a routine for gastric cancers because the yield of a CT scan in gastric cancer of the chest, CT scan of the chest, the yield is pretty low for a gastric cancer. So our investigation of choice would be a CT scan of the abdomen and pelvis. PET scan only in case of an OG junction adenocarcinoma.
Okay. So the patient is diagnosed to have a locally advanced carcinoma of the stomach, cardia, and proximal body. So he was seen by another surgeon and planned for a diagnostic laparoscopy. So this, I was not in the picture till this point. So the diagnostic laparoscopy showed a growth along the lesser curve of the stomach, some amount of ascites, about 200 ml, peritoneal deposits in the right paracolligator, right subphrenic, and omentum. We're not sure about the PSA. It was not calculated by the surgeon who did the laparoscopy, but I assume it was greater than 10. The biopsy was taken from one of the peritoneal deposits and the procedure was abandoned. Biopsy suggests of metastatic adenocarcinoma, at which time the patient was referred to. So now about the plan of management, my question is for Dr. Raja. Patient has come to you with good performance status. He is open to all lines of modality, a doctor himself. So, sir, what would be your next line of management? How would you counsel the patient? What would you do from this point?
Dr. Ajit, obviously, systemic therapy comes to mind, but after going through this particular meeting and looking at the peritoneal disease in close review, you can't qualify all peritoneal disease as the same. So you need to then look at whether they are localized or diffuse, and invariably you would like to look at either a PCI index or try to arrive at some sort of a decision making. It's very obvious, once again, using the the Japanese staging system, that if you have a very localized P1, then it is still eminently at some point resectable, or surgery is going to do the best job. But if you have a diffuse peritoneal disease, or if you think you have a P3, whichever system we follow, or simple common sense approach, if it's laparoscopy shows multiple metastasis, then you know that systemic therapy is going to be the real deal in such a patient. So suppose if I am thinking that at some point there is going to be a very aggressive surgery added to it, then I will approach it from a neoadjuvant perspective. Then I will look at a triple drug regimen like a DCF or a FLOT as a neoadjuvant approach, try to cytoreduce the disease, and then talk to my surgeon about that interval cytoreductive surgery and so on and so forth. Or if I realize that it is going to be purely advanced disease and surgery may not be contributing, if that is the decision, then I will lean towards predominantly systemic therapy. And at that point, we talk about 2 drugs versus 3 drugs, so on and so forth. But now, some more additional data has come over the past couple of years that we need to look at additional biomarkers, like we need to look at the MSIs and PDL1, and we now routinely start doing the HER2 for all our gastric malignancies. And there is very, very exciting data that if you have a metastatic disease, if it is HER2 positive, addition of HER2 agent plus immune checkpoint inhibitors. If it is HER2 negative, then addition of immune checkpoint inhibitors alone. Very, very impressive data has come out in 20 and 21. So I will be calculating all that in my mind. But again, of course, it's going to be a really two-way street discussion with our surgical team and taking this forward.
Ajit, one second. I just want to ask you, Ajit, and if there is peritoneal mets alone, that peritoneal disease alone is different. Peritoneal disease with ascites of 200 mLs is present. And there, what is the consensus?
Sorry, sir, you're asking whether there is a difference in treatment between a patient having only ascites and a patient having defined peritoneal mets. Is that the question?
Yes, exactly.
Ajit, I can also add to that. When we looked at the if peritoneal cytology, ascitic fluid cytology is positive, then curiously, if you look at the Japanese staging system P0, the outcome is worse in P0 as compared to P1. So
yes, exactly.
It is akin to a diffuse disease. And therefore, I will be strongly thinking that the patient should be shifted towards more and more systemic management, sir. If that is the answer, but of course, I'll let I answer the question.
No, that's what exactly I expected, Dr. Raja. Thank you.
Surprisingly, peritoneal cytology positive alone does worse than defined peritoneal disease. It may be an isolated event. So now, of course, we have discussion, and I'd like Ajit Poineer to pitch in. How many cycles of chemotherapy would you go for? Additional markers we've already decided, Dr. Raja has added to the discussion, and how aggressive to be with therapy. So this guy was very good performance status, very motivated. So I think he was willing to go for the whole hog. So what kind of chemotherapy, Dr. Ajit, would you decide? Like triplet, is it DCF or FLOT? Is there a difference between the two regimes? How closely do you place the chemotherapy? Is it 2 weekly or 3 weekly? Can you just enlighten us a bit?
Yeah, thank you for that question. Yeah, I fully concur with what Dr. Raja said about the decision point being in a multidisciplinary meeting to decide with the surgeon, are you going for a curative approach or it is just a palliative approach, and that basically decides what to do next. And we definitely do the CPS score and the HER2. assume for this case, we are going to look for a curative approach because you think that the peritoneal disease is minimal. We prefer to use FLOT, 4 cycles of FLOT. Previously, I had used DCF, which is very toxic. In some patients who are very young and very fit, use a modified DCF. But for all practical purposes, now we have gone to FLOT regimen, which is every 2 weeks, 4 cycles.
Yes, thank you. So this gentleman received 6 cycles actually of upfront DCF. I think the reason was he was from Nigeria and he probably had to go back. So that, he couldn't come back immediately after 4. So he received almost full course DCF, tolerated it well. Next. And post-chemotherapy came to us again with excellent performance status. He was eating well, his ascites had disappeared. Dr. Jairaj will take us through the imaging so that we can all see what happened after the chemotherapy. Share the screen.
Are you all able to see the screen, please?
Yes. Yes.
So this is the post-chemotherapy pre-surgery assessment scan.
Again, we are starting at the abdomen, and as we come along, you can see that there are these nodules still persisting, but much less in number. And as we go down further, the number of nodules is decreased. The peritoneal nodules that were a little more prominent have become less prominent. I mean, this is the way we are able to see by CT morphology, able to determine that there is a reduction in the number of peritoneal nodules. And thereby, we would say that there has been a response, a good response, I should say. So as we come down further, there is a notable absence of ascites right now. So I'm just going down into the cul-de-sac of the pelvis.
So, Dr. Jairaj, is there a radiological criteria you use, an objective criteria in patients with peritoneal metastasis to say that this is the response? It is a partial response, it's a complete response, it's static disease. Do you have something from your radiological society which helps you to?
Yeah, the RECIST criteria is there for large lesions. But for micrometastasis and smaller peritoneal lesions, there hasn't been an equivalent. So we go only by perception, a visual perception of identification of these various sites of the existing disease and comparing it with the pre-treatment and post-treatment imaging studies. Particularly the PET-CT has been recommended. We compare the two and then look at not only the CT morphology, but if these lesions, any of them did show some element of FDG avidity, we again go back to look at the FDG avidity and compare the two. Again, it's a question of visual perception and comparing it point to point and identifying whether there has been a gross reduction of disease and notably with improvement of the symptoms of the patient. I think we have to go ahead and think that there has been a good response.
Thank you, Dr. Jairaj. So,
Ajit. When post-treatment, isn't it a PET scan is advised rather than the just ordinary CT, Jairaj or Ajit?
So the thing is, sir, actually the CT, if it has been done first and you can do a repeat CT, that will show you the response. PET is very good, I think, for picking up distant sites of disease such as nodes, etc., liver mets, but not so good for peritoneum. So for the peritoneum as such, PET will fail.
Okay.
So, sometimes a lot of patients come to us at PET-CT, and I'm sure Dr. Raja will agree. So they already come with a PET-CT. So then, we don't repeat the PET-CT. Sometimes we just get the PET-CT reviewed. One thing, of course, is certain units do an MRI also, contrast MRI with diffusion-weighted imaging and body sparing. Maybe Dr. Jairaj can just tell us 2 points about MRI, whether it will complement the information from conventional CT.
Well, MRI has been sensitive because it gives a good amount of soft tissue contrast. And thereby, the lesions, particularly diffusion-weighted imaging, is comparable to PET imaging. And we can identify small lesions. And the resolution on the diffusion-weighted imaging is not that great. But still, we could, to some extent, identify lesions which are comparable with the PET-CT.
I have one thing to add to Ajit. This question is often asked, whether the PET-CT is indicated and PET-CT is superior or inferior, whether there is a guideline. But oftentimes, this is what we tell. See, the conventional PET image, PET-CT, what the Western literature describes is just the PET. But in India, what we do, I mean, of course, they also do, but what I'm talking about in India, when we mean PET-CT, it is a CT scan, CT PET, that's what we are talking. And then imagine that the patient has to undergo a CT scan of the chest, abdomen, and pelvis, and whatever, so on and so forth, and whatever other regions. Our PET-CT scan completely covers all the regions. Remember, it is a CT scan, and it has got a CT contrast, and then the PET is overlay on it. And in our setup, it works out to be a much economic modality when we compare all the three put together. In our setup, I'm talking. Of course, in a major institute, there may be subsidiaries and so on and so forth. But in our setup, single investigation, all regions are covered, and any doubtful areas are addressed. And so particularly in this patient, there was a question on a paratracheal lymph node. So those are all the places where I think a comprehensive CT PET, which is what we do, is economic, comprehensive, answers all questions. So I don't think we should shy away from saying that we do PET-CT.
Yes, definitely. So thank you.
Ajit, can I ask Dr. Raja and other panelists?
Sure.
In a patient that you're diagnosed to have a peritoneal metastasis and you're planning on systemic chemotherapy upfront, would you take a decision to consciously stop the chemotherapy halfway, for example, say after 3 cycles, to see whether there is any ongoing response? Because sometimes the patient might progress even while on chemotherapy, and you might lose the window of opportunity to do some sort of a surgical resection. So what is the role of...
Very typically, if you are looking at a combined modality approach, pre-operative, very typically we'll do the 4-cycle FLOT. We have, as Ajit, when you were mentioned, we have completely switched over to FLOT. Whenever we have a pre-operative in mind, FLOT 4 cycles, repeat a scan, make a decision, not just scan, repeat endoscopy, everything, and then be aggressive on surgical option and offer it to the surgical team to look in. That's what we do, sir.
Thank you.
So my question to Dr. Marc Reymond first, and then to Dr. Yonemura, just warming up for the big questions. So this patient came to me a week after his initial laparoscopy. So at that time, of course, we didn't have these protocols in place. So my question first for either Dr. Yonemura or Reymond to take in sequence is, would you look at re-laparoscopy for this patient so that you could assess the disease on your own merits? And would you advocate neoadjuvant intraperitoneal therapy either as PIPAC or LAP-HIPEC when the patient saw you a week after his initial laparoscopy? Or would you just come into systemic therapy since you'd already undergone LAP and then go on to further therapy as prescribed?
We perform laparoscopy to determine the patient should be operated or not. And at the same time, we perform laparoscopic HIPEC using docetaxel cisplatin. And if the patient are diagnosed as eligible for operation, we perform operation 1 month after the laparoscopic HIPEC.
Okay. So you would do a real. Dr. Reymond, can you take the question? What would be your thoughts? Professor Reymond?
May I have the screen, please?
Yeah.
You were on the screen.
So you want to share?
So I wanted to share this publication, which is very new, okay?
Sure, sir.
So we are in a situation where the gastric cancer is metastatic, and you see here that in Europe and the US, also the range is highly variable. Only, let's say, 5 to 14% of the patient get a gastrectomy. So the majority of the patient will not get a gastrectomy in this situation. So in Germany, we have no reimbursement for PET-CT in gastric cancer. So nobody does it. this patient will certainly receive FLOT. And now, increasingly in Europe, he would receive PIPAC in alternance with FLOT. So, meaning FLOT, FLOT, 2 weeks pause, PIPAC, 1 week, and FLOT again. So that's done increasingly and with good results. It's well tolerated. And PIPAC does not prevent the restart of FLOT immediately after PIPAC. The other way is not true because FLOT is effective, but it's pretty toxic. And you will agree, Dr. Pai, that we have many patients that cannot complete the full schema because they just don't tolerate it. So we wait 2 weeks between the last chemo dose and the PIPAC, but in fact, it's just postponed the next FLOT dose by 1 week. So it's, we believe it's acceptable on the basis of the evidence available, which strongly suggests that adding PIPAC with cisplatin will double survival of this patient and will give to 1 out of 10 patients a chance, or 1 to 14% in France, a chance of a curative resection.
So I think what the jury says is that we should definitely re-laparoscopy patients when they come to us early, give them intraperitoneal therapy, PIPAC or lap PIPAC, depending on the philosophy and what school you subscribe to. More and more PIPAC nowadays, and then intersperse with chemotherapy, and then assess them after completion of a prescribed course of IP and systemic therapy. So,
Ajit,
yes, sure, sir.
Yeah, can I ask Professor Yonemura and sir, how simple or how complicated is the total peritonectomy? You mentioned about all the compartments, and can we do, are we able to do a complete peritonectomy? Because if you leave a small peritoneal layer somewhere, there is bound to be recurrence of the peritoneal disease.
Yeah. And we never do all the peritoneal resection. We remove the residual metastasis on the peritoneal sector. We remove. Okay. In some case, the removal number of peritoneal sector may be less than 5 or less than 4. So usually we remove greater omentum, lesser omentum stomach D2 dissection. And in the case of the female, we remove ovary and uterus and pelvic peritoneum. Or in some cases, we remove the right hemicolectomy to complete removal of omental metastasis or the parachoric gutter removal. We never do the total peritonectomy.
But Professor, as per the literature, if you leave the peritoneum, there is bound to be recurrence of the disease in the normal peritoneal area in due course of time. What is your experience about it?
Yeah, we never do the, we preserve the peritoneum as much as possible.
Okay. Fully agree.
The peritoneum involved by microscopic involvement. So in the micrometastasis left in outside the operation field, we treat by hyperthermic.
Okay.
Okay.
So west meets east or the opposite, but it's the same in Tubingen. So we do not remove normal appearing peritoneum. And by the way, it's completely impossible to make a complete peritonectomy. 70% of the peritoneum is visceral peritoneum, and you cannot remove the visceral peritoneum from the organs. So if you want to remove the peritoneum from the stomach, you have to remove the stomach. If you want to remove the peritoneum from the uterus, you have to remove the uterus. For the bladder, in some cases you can remove the peritoneum without the bladder, because it's parietal peritoneum. But for the visceral peritoneum, you have, if you want to get the patient to remove macroscopically involved peritoneum from a visceral organ, you have to remove this part of the organ also, and that's indeed the limitation. In particular, on the small bowel, you cannot remove all the visceral organs to get the patient macroscopically tumor-free. So you have to select your patients, and therefore you can only do that in patient. It's only meaningful to do that in patient with limited, and in gastric cancer with very limited disease.
Thank you very much, sir.
Dr. Ajit, can I ask a question to Professor Yonemura?
Yeah, please.
Professor Yonemura, very interesting talk. Thank you so much. In your data, you showed that the site of the peritoneal metastasis sometimes determines the prognosis. If they have peritoneal mets on the ovary and uterus, they do very badly, while in the left paracolic gutter, they do well. Is there any explanation for this?
Yeah, and we cannot get 5-year survival in patients involved uterus, ureter. However, the other parts of peritoneum are involved. The surgeon should remove these sectors as much as possible. But regarding the long-term survivors, surgeons should remove less than 4 peritoneal sectors. This is our limit to obtain the long-term survivors. If the PCI is very high, we should not remove the peritoneum involved. So we have, I recommend side reduction surgery for the patient with PCI less than 10 and small bowel PCI less than 4.
Thank you.
That is very important.
So we'll go to the diagnostic laparoscopy. So it was essentially a clean abdomen. There's some amount of scarring, the right paracolic and subdiaphragmatic. We'll just show you the video. Can you see the video?
Yes, you can see it now.
Yeah, so this video is of diagnostic laparoscopy done in 2018 for this patient post 6 cycles of DCS. So essentially it was a clean abdomen. There was no ascites, small bowel mesentery, and the visceral peritoneum was normal. Momentum was fine. There was a growth in the body of the stomach. Liver surface was pristine. There was some amount of scar in the right paracolic, and I think both subdiaphragmatic. Unfortunately, we didn't have access to the initial laparoscopy. We couldn't retrieve it. So we could not compare it to the initial laparoscopy to show the difference with chemotherapy. A little bit of scarring. Sorry, the video is scrubbing a bit. A little bit of scarring. You can see then the subdiaphragmatic on the right side. So
excellent result, actually.
Yeah, next. So a question is to Dr. Ramakrishnan about the role of intraoperative peritoneal cytology. So do you do it routinely for all patients with advanced gastric cancer? What is the method you use? And do you look for a frozen on the peritoneal cytology, for example, if the patient is already pre-treated and you're proceeding to Hipec, or do you wait for the next day to get the final report? You can also throw the question to the international speakers who may be able to shed some light on peritoneal cytology.
Yeah, so we don't do peritoneal cytology as a routine. We did a study of around 100 patients to know what is the percentage of patients who have a positive peritoneal Lavage cytology. And it was a very low yield. It was, I think, around 8% had a positive peritoneal cytology. So after that, we stopped doing peritoneal Lavage cytology as a routine procedure. And we do not do a snap cytology or a frozen section. We always submit it to a cell block, and only then we look at the result. I mean, there are methods by which you could improve the yield of a peritoneal Lavage cytology using immunohistochemistry or other FISH or some other techniques, but routine cytology yield, as far as in Indian patients, I've also come across a few other publications, is pretty low. It's around 8 to 11% in T3 and above gastric cancers. So that has been our experience, but I don't know, maybe in Japan or in Germany, the yield of peritoneal Lavage cytology might be quite higher. I would like to hear from the.
Yeah, we can ask Dr. Yonemura and Dr. Reymond about their experience with intraoperative peritoneal cytology. They obtain it on the same time, like a frozen section, or is it always a next day, or you wait for final pathology? Dr. Yonemura?
Yes.
Yes.
Intraperitoneal cytology after neoadjuvant chemotherapy is a very good predictor for prognosis. When the intraoperative cytology positive, the prognosis may be very bad. But even if the intraperitoneal cytology positive after NIPS, some patients survived and cured. So I think the intraperitoneal cytology after NIPS may be the indicator for prognosis. So I recommend it's very important to perform cytology after NIPS.
Dr. Reymond?
Well, so in Germany, we have to learn from the East, because I wouldn't say nobody does peritoneal cytology, but it's well, it's not the routine. And in fact, we have data in PIPAC, both from Lyon and from Odense in Denmark, confirming what Dr. Yonemura just said. So it looks like that the cytological response should be or might be part of the PRGS to decide about further therapeutic measures.
Yes. I think one thing about the cytology is, which we probably will flesh out in the years to come, is whether you should always wait for the final pathology or we can do a frozen. For example, last week we had a patient with advanced gastric cancer who came to us after chemotherapy. No peritoneal metastasis ever diagnosed. So we put in a laparoscope, the abdomen is clean, we just got a proximal stomach cancer, standard straight shot. So we did a peritoneal lavage and then we sent it for a frozen. And the frozen of the peritoneal lavage did show malignant cells. So this patient was counseled and we added a Hipec to his procedure, where normally we probably might have avoided a Hipec. It may not be conventional, but it's something to think about in a patient who has a clean peritoneum, a resectable disease. What if the cytology comes positive? Do you back out? Give him lap Hipec if the abdomen is open, or a PIPAC, and then go back in when the cytology is negative. So there are multiple substrata in this already very small field where you can, have improvements. Next.
So for lavage, the question is answered by a phase 3 randomized trial. So this is not indicated for lavage. Published by the group of Jimmy So last year, so it doesn't bring anything.
Introp findings showed residual thickening the lesser curve to the proximal stomach, momentum and transverse colon adherent to the abdominal wall, and patchy scar tissue, as we said on laparoscopy, in both subdiaphragmatic peritoneum. Nodule in the cul-de-sac of about a centimeter size, and liver, spleen, small bowel all normal. His PCI was staged as 4/39. That's both subdiaphragms and in the pelvis, and he had an en bloc anterolateral peritonectomy in this case. We usually go extraperitoneal initially, so we already mobilize the peritoneum. The PCI cutoff, what is the PCI cutoff for offering Hipec? Like Dr. Reymond to speak, and also Dr. Yonemura and even Dr. Ramakrishnan. So we know that it's about 6. That's what literature says. How did we arrive at this number? How did we decide that this is the cutoff to offer Hipec? Dr. Yonemura?
Yes.
Yeah.
Yes, from this finding, I recommend total gastrectomy because the lesser curvature was involved until the proximal stomach. And also the diaphragm was involved. So I will remove both sides of diaphragmatic peritoneum and stomach, total gastrectomy and total omentectomy, including removal of lesser omentum. The lesser omentum is cut, just attachment of the liver. and removal of hepatoduodenal ligament, including the resection of number 12 lymph nodes. And we preserve the pelvic peritoneum in this case, but parachoric gutter may be removed because of the complete removal of greater omentum.
He had a nodule in the pelvic peritoneum, so he did require a pelvic peritonectomy. What about IP chemo port placement? Would you routinely place IP chemo ports for all these patients?
Pardon?
Would you routinely place a chemo port or intraperitoneal, prolonged intraperitoneal?
Yeah, but if we perform peritonectomy, we don't place the IP port because the intraperitoneal chemotherapy after operation does not spread all over the peritoneal surface due to the adhesion after peritonectomy. So in this case, we never place the IP port. In addition, if we place IP port, about 30% of patients developed IP port infection. So we inevitably remove the IP port after operation.
And I can just ask, Ajit, can I ask one question?
Hi.
Yeah. Hi. When you do once a peritonectomy, there will be extensive adhesions will form inside the abdomen. So as you said quite rightly, the chemo will not spread all over the abdomen. And secondly, it has been found number of patients do develop, if not a significant number, do develop intestinal obstructions with the total peritonectomy. What is your experience, sir?
After peritonectomy, almost all patients developed adhesion. But we performed extensive intraperitoneal lavage in all cases using a lot of salines. So the adhesion is not so severe. Very mild adhesion was found all around the resection site. And that is the reason why I don't do IP chemotherapy after peritonectomy.
Thank you, sir. So this is a specimen, resected specimen. You're not included the subdiaphragmatic peritoneum, which is not in this picture, but essentially a radical total gastrectomy, omentectomy, lesser omentum removal, omental bursectomy, and that's a pelvic peritoneum specimen. And of course, the standard D2 gastrectomy, and then a reconstruction as below. And then he received cisplatin and mitomycin fixed dose, 150 and 20. He's quite a big guy, about 6'4" or 6'5". 4 liters of saline. Intra-abdominal temperature, we achieved 42.5. 0.5 less than probably what Dr. Yonemura would have been happy with, and ran it for about 90 minutes. We always use the open method. We never closed the abdomen. He recovered very well, had no major morbidity. So pathology shows tumor in the lesser curve, residual signatory carcinoma, T4 status, direct involvement of the omentum, multiple nodes positive, LV and PNI present, no extranodal extension. He was HER2 negative in initial pathology, and there was a deposit in the pelvic peritoneum alone. So that was the only site of disease. This post-hoc PCI pathology was just 1/39. Initially, we thought it was 4/39. We have no clue what he was before chemotherapy. Apparently, he was a patient who had a very excellent response and a very low peritoneal carcinomatous burden. So my question for Dr. Raja is, what do you do next, sir? Since he's already received 6 cycles of DCA, what would you recommend for him as adjuvant, or would you offer him adjuvant at all?
In some other setting, if I had started off with FLOT, I would have done 4 cycles of FLOT and then followed by 4 more cycles of FLOT. And even in Professor Yonemura's approach of comprehensive therapy, you see that there is pre-operative therapy followed by post-operative. So what I'm trying to say is that I would definitely consider some form of adjuvant therapy. That's for sure. Then I will look at what was received, what was the toxicity, and so on and so forth. If the patient is doing well, does not have any major toxicity due to the previous regimen, in a good physical status, And I would recommend that consider some form of adjuvant chemotherapy. I would consider something like definitely adding something like a capecitabine or an oxaliplatin, and something to finish off the adjuvant. I would strongly think about that for a duration of about 3 to 4 months. That's what I think I will do in this patient.
Right. I think IP port, they have answered the question that post-op it does not work well. So again, a question to you: what is the uptake, or we put a lot of IP ports. We know sometimes patients don't want IP therapy. What is the uptake among patients here in India about IP therapy? Because IV itself, they are quite reluctant to take. So when you add IP therapy,
yeah, that was one important question I wanted to ask Professor. Professor P.K. Reddy asked that question. So the point is, I have a mixed opinion about the IP port, and I really wanted to listen from Professor Yonemura and Professor Reymond how they use intraperitoneal normothermic temperatures and use of chemo ports. That's something that I really wanted to hear from them. And one very, very, I think, good learning for me, what he said is that if there has been some amount of peritonectomy, or if there has been a reasonable peritonectomy, IP chemo port is not going to be useful. That is something that is good for me, that I take home as a message. But I would still, our take to answer your question, the patient seems to be less enthusiastic to take it, but we have tried it in few patients. We have faced procedural difficulties on following it up. But having said that, I really am keen to learn about how to use this IP chemo port in a better manner, and I think I would be happy to listen to them, more experienced teams.
Well, we don't. It's a very short answer. In Western Europe, nobody uses intraperitoneal chemotherapy, catheter-based chemotherapy,
Dr. Reymond,
which is not a recommendation or based on evidence whatsoever. It's just a reality. Nobody does it.
Thank you, sir. That's what is our impression, but it's nice to hear. I would
Ajit,
also...
if I can just ask a question, I noticed in the histopathology that it was reported as a signet ring cell carcinoma.
Yeah.
Now, our experience with signet ring cell carcinoma in India has been extremely bad. The patients don't do well at all. So, would you consider, I mean, the question is open to all the panelists, would you consider performing cytoreductive surgery and Hipec in a patient with signet ring cell carcinoma? And what has been your experience? And would you probably prefer some other modality of treatment like just a PIPAC, or would you term it as a palliative treatment?
Dr.
Professor Reymond, what would be your take?
So we have published on that in Tubingen. The answer is no. So the results of cytoreductive surgery and Hipec in signet ring as a gastric cancer are not good enough to justify the surgical injury. So the rate and the time point of recurrence are so that there is no reasonable balance between risk of benefit of this heavy procedure in this indication. So, and we, in fact, if you look at the role of cytoreduction surgery and Hipec in the curative situation, I'm not talking of the prophylactic situation. I'm talking of the curative situation. To my knowledge, as of today, there is no single randomized trial ongoing in the curative situation. Zero. So there is no evidence supporting this therapy, and in the next 10 years, there will be no further evidence. And if you now look at the recent articles on the so evidence-based reviews on cytoreduction Hipec in gastric cancer, they are extremely negative. So it's not something that is supported anymore. On the opposite, it does not mean that NIPS or PIPAC will not have a future in this setting. But this has now to be demonstrated. If there is no, I don't know how is it in India, but in Germany, if you cannot provide randomized results, the insurance will refuse to pay for therapy, or only allow it in selected cases you have applied for. So this is now becoming increasingly difficult in Europe to perform the cyclosurgeon and Hipec in gastric cancer.
Thank you.
I have a question.
I'll just ask one question. Professor Ramakrishnan, that was a good question which you have raised. And I would like to ask Professor Reymond, at least we have to do the total gastrectomy in this particular case and then excise the nodule in the pelvis. So I think we are, I mean, that part of it is perfectly correct, isn't it?
So we are performing cyclosurgeon Hipec twice a week in various indications. And I agree with Dr. Yonemura. When you see these laparoscopic pictures, it's self-evident that you would try as a PCI below 6. And we would also make cyclosurgeon Hipec. The only point is signature cancer. And so when I see signature cancer, I know that it's like playing with fire. So in some patients, you might have a good results, but other patients will just have their tumor exploding within 6 weeks to 12 weeks after the operation, which is probably due to the favorable growth condition in the surgical wounds with angiogenesis, growth factor whatsoever, oxygen for a tumor which is biologically extremely aggressive. So we have not only to look at the mechanics of it. Yes, I have taken it all. No, I didn't let any unseen tumor node, because we know Sugar-Baker wrote it that this node will kill your patient. That's true. But on the other hand, if the tumor is biologically so aggressive, it's of no help for the patient. And in some cases, it might even be harmful. And that's also something we have to talk about. We always talk about the success cases, which is fine because this patient had the benefit, but we never talk about the patient who had an early recurrence after a heavy procedure. Some of them having major complication and even occasionally postoperative death. So we have to put all of that into the balance in a situation where we don't have a very strong evidence. So it's and when you don't have a strong evidence, again, I don't know how it is in India or in Japan, but in Germany we have clear guidelines from the health assessment authorities, which say basically you need randomized data. If you don't have randomized data, then you should look at the best possible evidence. In some cases, randomized trials are not possible. We understand that, but then you have to look in particular at the risk of the procedure if you cannot prove the benefit. And if the risk is high, then you have to be extremely reluctant with such a procedure, which is logical. And we should, we should be self-responsible as peritoneal surgeons and aggressive surgeons to stay within the lines, because if we don't, we will never get acceptance for the medical oncology community. And once again, it's impossible to treat patients if we don't do that together. So sorry, but the standards are evidence-based standards, and we have to cope with them. If we don't that ourselves, the others will tell us that we should do.
Thank you very much, Professor.
Thank you. The point is well taken. We need to tread carefully and we need to discuss these patients on an individual basis. The patient received capecitabine and oxaliplatin to 6 cycles. He completed his chemotherapy in 5 months. We already discussed that the patient does require some amount of adjuvant therapy after full course, even after full course chemo. He presented up 10 months from surgery with intestinal obstruction. And Dr. Jairaj can show us the imaging.
Yeah, we can see Jairaj now.
Yes, sir. Thank you for that. And we are just scrolling down the abdomen, and we can see that subdiaphragmatic, not much of disease there, but then you can see some larger omental nodules over here. The intestines are all stuck, the small bowel, there are a lot of adhesions between the bowels, and the mesentery is thickened and shows some nodular disease. So it has extensively involved the abdomen, and the bowel is now stuck one-on-one. And this is the cause of the subacute intestinal obstruction that the patient presented with. And one can see that it's almost like plaque-like thickening of the abdominal wall, where the existing peritoneum was has actually been diseased totally. And you can see all the bowel loops all stuck one-on-one and causing the obstruction that the patient is presenting with. The amount of ascites is less because probably the space for accumulating the fluid is not really there. There are no pockets there. They're all stuck one against other, and it is a frozen abdomen, I must say. So that's how it would look to a laparoscopic surgeon.
Yeah, thank you, Dr. Jairaj.
Jairaj, one thing I would say,
yes,
for a laparoscopic surgeon, this is a nightmare to go into the abdomen.
Yes, sir.
Yeah, because wherever you try to insufflate, you will not be successful. Somewhere or other, you try to injure them. Either by open surgery or by laparoscopy, they are difficult.
True, sir.
So obviously this patient is obstructed the recurrence, so IP therapy immediately is not an option, but we'll take it a little later. So he had ascites, dilated multiple small bowel loops and laparotomy, diffuse mesenteric nodules, extensive adhesions, and a point of transition, the dominant nodule is the mid-ileum. There was an inadvertent injury to the jejunal loop adjacent to the esophageal anastomosis while doing an adhesive lysis, which was repaired. And he had repair of the jejunal serosal injury with a patch, and then diversion stoma, an end loop ileostomy, just proximal to the most first level of obstruction. He did develop an intracutaneous fistula on post-op day 7, but it managed with conservative measures with TP and octreotide and IVF support. He was discharged on post-op day 34, eating a normal diet. We recommended only best supportive care. He did go back to Nigeria and take some systemic therapy with local oncologists. We don't know what he did. And he passed away about 10 months after his second operation. But he had a good quality of life in those 10 months. He was able to eat a normal diet till the end. We were in touch with his family. So his DFS from the time of surgery was about 10 months till the point of intestinal obstruction. But his overall survival was 26 months. So I know it is signet ring and you're talking about thing, but he did have a reasonably good quality of life for over 2 years. So I'm not sure how well he would have done with only systemic therapy. But yeah, the point, Dr. Reymond's point is well taken that we have to be very careful when we tread in, because as we are able to offer better and better outcomes to our patient because we are better and better surgeons, better ICU anesthesia teams, it's a very point at which we have to be very careful not to overstep, because the ability to perform an operation or a procedure does not constitute an indication. Just because you can do a safe operation doesn't mean that you should necessarily do it. So the point is very well taken, Dr. Reymond, that you have to be very careful when we take up these patients with aggressive histologies, have good counseling, have a multidisciplinary, look at the current evidence, and only if the evidence is better than the current standard of care for aggressive therapy, we should provide it. I think that brings us to the end of our panel discussion. It's been an amazing panel, I think. I'm glad we just had one case. And all the panelists, thank you very much. Dr. Yonemura, Dr. Reymond, Dr. Raja, Dr. Ramakrishnan, Ajit Poineer, Virmanayagam, and of course, Dr. P.K. Reddy for marshalling our thoughts and, keeping us in line. I think it's been a great discussion.
Ajit, one thing I would like to say. You have given an excellent message. The message which is given by you was very well taken. It should have been taken by everybody, actually.
Yes, sir. Thank you very much. I think we will also get the best out of these presentations and maybe making into an e-book or a PDF with the faculty's permission, and then circulate it to the faculty and other people who have attended so that they get the essence of what has been discussed here. That it is not like we listen today and by tomorrow we are, going about our daily work. So we will extract the best and send it as an ebook or a PDF to everybody involved in this meeting.
Ajit, only one question, if you permit me, please.
Definitely.
I would like to ask Professor Yonemura and Professor Reymond that with the advent of all the newer knowledge of genomic profiling and the the current knowledge of the dabrafenib and LIM1 and all that one, is there anything more that we can do in such patients by doing genomic profiling and then trying to choose which patient what, and with the advent of the immunotherapies and all, is there anything more that we can add as systemic agents in these things can improve the outcome? So currently, where is this field heading? Professor Yonemura and Professor Reymond. Thank you so much, sir, both of you.
So perhaps I'll start. The answer is clear, yes. So they are, we are now at a time point in the treatment of peritoneal disease where the possibilities are broadening exponentially, both with systemic therapy and with local regional therapy. And indeed also all the possible combinations between them and all the different possible sequences between them. So we are now coming into an area where we just start to understand the complexity, and we should create, I think the most important, that's a huge task, it's very clear, okay? It will take 10+ years to understand what we are doing and which are the consequences. So we need a multidisciplinary research network, not only a single institutional, that's too small. And we should also allow people to collide, okay? We should allow collision of ideas to generate innovation. And we should stop just being religious because I'm whatsoever an immunologist, a peritoneal cancer surgeon or medical oncologist or whatsoever. I think that the key is truly there. There are fantastic opportunities. For example, it looks like that we could generate an Ascorbal effect, like it's known in radiotherapy, in the peritoneum, for example, with PIPAC, perhaps with other techniques, in patients who have received previously systemic immunotherapy. So we have several individual examples of patients who had all possible chemotherapies, who then received immunotherapy on an individual case basis because it's expensive and it didn't work. They were still in progress, and then they came as a last chance to PIPAC, and they had spectacular, long-lasting response nobody was expecting. It's not because of PIPAC, or it's. I believe PIPAC just acted as a local immunostimulation and just allowed the systemic response to work. And once again, Jimmy So is now performing the first phase 1 with the support of BMS, so with nivolumab, looking exactly at this point. That's one of 100 possible studies. So please talk together, meet together, come to meetings, exchange ideas, and coordinate the research protocols. It's a huge playing ground with a lot of toys, and so far few kids playing with the toys. So we should truly try to distribute the toys and not all to try to take the same toys as the kid do and fighting for a single toy. But we should just try to use the huge power of the community working in the meantime on peritoneal disease. And that's what I try to do with ISSPP. That's also what I told you at the beginning. PIPAC is nice, but the true challenge is not PIPAC, it's therapy driven. The true challenge is understanding disease, transforming patient care.
Thank you, Dr. Reymond, for summarizing it beautifully. Dr. Yonemura, do you have any?
Today I talk about a very small case of cured patients by our treatment, but almost all patients died due to the peritoneal recurrence. So we have to study more about molecular targeting molecules based on the gene abnormalities, but we have no good drugs now. We started nivolumab 2 years ago, but the result is not so good. So we need a more effective treatment, chemotherapy drugs. So I am waiting for the new drug effective for peritoneal metastasis. Thank you.
Thank you. Thank you. So with Dr. P.K. Reddy's permission, can we close the session, sir? And we'll ask Dr. Ajit Venio to just summarize briefly what all the speakers have, just to give us a few take-home points. The permission of the faculty.
Yeah. Thank you, Ajit. And let me share my screen. Yeah, I hope my screen is clear.
Yeah,
so summing up, it has been an awesome experience to meet. Normally we meet experts in their fields, but today we are actually meeting pioneers in their field and to listen to their thoughts and how they approach their cases. It has been amazing. I bring you regards from the Royal Hospital in Muscat where I work. So these are my thoughts, what messages I have got, and if there is any mistakes, you're free to stop me and correct. So the first talk was kicked off by Dr. Ajit, my namesake, friend, and a surgeon par excellence. And I remember telling Dr. Pratap Reddy that we are very fortunate to have such beautiful hospitals and such excellent surgeons, which makes our position here strong. So he highlighted the problem of peritoneal carcinomatosis with a very, very dismal 5-year survival and the need to do something about it, and the poor response to IV chemotherapy. He explained the biological rationale of direct exposure to high dose of chemotherapy and the various methods to ensure this, and he presented data from various trials, which are mostly positive. Dr. Raja, my colleague, he reviewed the data on chemotherapy in gastric cancer with peritoneal mets, and also I emphasized the limited efficacy of systemic therapy on peritoneal mets. He reviewed the intraperitoneal Hipec and PIPAC data, and also the German data, which showed that expertise matters. Higher volume centers do seem to do better, and so we are glad that Apollo is taking up this project. Definitely there is a significant improvement by using these methods, but most of the trials are limited by a small number of patients, except of course Professor Yonemura's huge data. Dr. Raja also explained the role of prophylaxis. Even if peritoneal mets are not present, maybe we can use it. And he showed us the algorithm that if you find peritoneal mets or peritoneal washings, how to give neoadjuvant and intraperitoneal chemotherapy, and then proceed with the surgery later. And also an interesting target LIMK-1, which is a marker for peritoneal mets, and maybe we can target it with dabrafenib in future. This is the standard, the NCCN says that if you find peritoneal mets in gastric cancer, treat it as metastatic disease. And this is the standard treatment for gastric cancer, first line with 5-FU, platinum, maybe taxane, second line with paclitaxel, ramucirumab. The improvement which has happened recently is the addition of immunotherapy, both in first line, in second line if MSI is high or tumor mutation burden is high, or even in third line where you can use either pembrolizumab or nivolumab. The question which I want to ask is, why don't we use these drugs, these immunotherapy drugs, as a part of intraperitoneal chemotherapy? And I'm glad that I came across this study. This is an ovarian cancer, not gastric cancer, called the ICONIC study, being done out of France, where they're using intraperitoneal bimonthly nivolumab. So that data should be interesting when it comes out. Dr. Yonemura was fantastic. He showed his complete research approach, how he outlined his meticulous approach to patients of peritoneal mets with sequential use of neoadjuvant chemotherapy, laparoscopic Hipec, NIPS, extended intraperitoneal lavage, and early intraperitoneal chemotherapy. and explained the purpose of removing the macromets by cytoretictomy surgery and micromets by all the other methods. He has done huge research to develop this protocol with a large database. Although he's very modest, he's saying only 20 got cured, but he forgot the 564 which record obviously had improved survival, which he didn't mention. He emphasized the importance of 43 degrees of temperature. He discussed the randomized trial, controlled trial of Hipec with improvement of survival of about 2 months, and the factors, prognostic factors which leads to cure. A very interesting data, very large data. Dr. Marc came out with PIPAC is a very innovative approach, there's no doubt. He came out with 7 questions and he gave 7 wonderful answers. The level of evidence is obviously not high. These are early days, randomized trial, but as he mentioned in adjuvant setting, we are going to get very level 1B evidence soon. In upfront setting, there are 3 studies, and one of the studies which he mentioned, the survival doubled from 7 to 14 months. In salvage setting, the data is only small amount of patients, 69 patients. Role of individualizing therapy, I'm very impressed that a surgeon could talk about genetic profile and different mutation profile, why the epithelial subtype is different from the mesenchymal subtype with a almost doubling of response rate. And he also very nicely explained the Tubingen algorithm of multiple PIPACs and neoadjuvant chemotherapies. He explained that the cost effectiveness, it is cost effective, especially in salvage setting. And as in neoadjuvant setting, there are small studies, but 10% could be converted to resectable disease, which is really good. And the most important, in about 25% of these patients are long-term survivors, which is difficult to get in this group of patients. So that is very impressive data. From my viewpoint, PIPAC is truly multidisciplinary because the surgeon is delivering the chemotherapy here. Peritoneal disease is a genuine problem. About 30% mets even after imaging, which means we need better imaging. And also we need more surgeons to appreciate the role of neoadjuvant chemotherapy. And I think Apollo Hospital is one of the pioneers in having a multidisciplinary approach. In my own institution, sometimes the surgeons sneak behind my back and do the surgery and then hand it over as fait accompli. It is something we're trying to dissuade them from doing. However, in peritoneal mets, IV chemotherapy is just not good enough. It does convert to negative cytology, which did improve disease-free survival from 1.5 years to 2.5 years, but did not change the overall survival. And this point is, I think Dr. Yonemura also pointed out that it is useful to convert, but it doesn't improve the survival much. The holy grail is we are looking what medical oncologists looking for is to methods to deliver high concentrations directly to the tumor. We use intrathecal, intraarterial, intraperitoneal. There is very good data why it works. There are 2 meta-analyses, and there are multiple meta-analyses on this actually, why intraperitoneal Hipec is impressive. The last one I saw was in 2019. There are higher complete remission rates, higher 3-year survival with same adverse reaction, but still, I think organizations are still insisting on more data. We have 3 major studies coming up: Periscope 2 from Netherlands, Gastric and Gastripec. Unfortunately, Gastripec has been closed because of low recruitment, but hopefully we can look forward to data from these. These are randomized data, and hopefully then this will become standard of care. The basic limitation as far as I can make out is drug resistance. They're very effective delivery systems, but getting the drug into the cell is only half the story. Because cancer cells develop resistance to chemotherapy drugs pretty fast. The standard drugs we use are effective, but not that great. And we really, what Professor Yonemura said, we really need better drugs. Intraperitoneal nivolumab is a good start. We have this occasional anecdotal reports of intraperitoneal trastuzumab with good response. In future, we'll have CAR T cells. This is for colon cancer and also only in mouse models. There's chimeric antigen receptor T cells, and we can have even vaccinia viruses for intraperitoneal treatment. So this is, of course, much in future. I will end with this, with Dr. Bryant's saying the peritoneum is the best target to improve survival in gastric cancer. And I think the problem is not with the surgeons. The problem is the medical oncologists to give much better chemotherapy drugs. Thank you very much.
Letting us know what and all we learned. So I think with this, we can bring the meeting to a close. I'll just request my colleague, Dr. Naveen Padmanabhan, to propose a vote of thanks. And heartfelt thanks to all the faculty, speakers, people from different time zones who have taken time and really involved yourself for 3 hours in a very, very niche field. Thank you so much for sharing expertise. And Naveen will just propose a formal vote of thanks.
So, thank you, everyone. So I would like to thank all the participants and the panelists, chairperson, and also the international experts. So a special thanks to Dr. Yonemura and Dr. Marc Reymond for accepting the invitation and being with us. So Dr. Yonemura has already, it is 10:45 in Japan, and he has logged even before us. So half an hour before us, he has logged in. So thank you very much for being with us. Professor Reymond, it has been a very marvelous experience listening to you, and we look forward to working with you in the future. So I also thank the course director, Dr. Ajit Pai, for initializing this meeting and successfully conducting it. And I also thank Dr. Raja, the speaker. It has been you have been very interactive with all the panelists, and you have brought up some interesting questions and addressed it. And I thank all the, first the chairperson of the panel, Dr. P.K. Reddy. Thank you very much for organizing this panel and bringing together everyone. I thank the panelists, Dr. Jairaj, Dr. Ajit Venur, Dr. Paramanayagam, and Dr. A.S. Ramakrishnan for being with us and bringing some interesting questions. So next, at last, Dr. Ajit Venur, you summarized the whole meeting in your presentation. You took some important notes and summarized all the important points for us. Thank you very much. I would like to thank the management of the Apollo hospitals, the chairperson, the vice chairperson, and all the team members, the medical superintendent of Apollo Cancer Hospital, Apollo Cancer Center, Apollo Proton Center, the top management, the COO of both the centers, for providing us with all the technical support and the logistical support. Here, I would like to thank the IT team and the marketing team at AACC, Apollo Cancer Center, and Apollo Proton Cancer Center for providing with the technological support. So I feel we will again meet up in a future meeting, and we'll work together as Dr. Marc Reymond proposed. Thank you very much.
Thank you very much. Thanks a lot for sharing your expertise and times. Thank you, sir.
Thank you.
Thank you, everybody.
Thank you. Thank you.
Thank you.
Thank you.